Okay, well, at least I was able to get that up. Okay. All right, good morning. Now I think we can get started. Should ding at me if anybody tries to join. All right, so how did you guys do on your reading homework? Any problems?
I got 100.
Okay, so pretty easy overall, pretty basic. All right, because I still haven't learned your names yet. I'm still working on it. Let me go down my list and see who's who and how you did. So are you Selenia? Is that correct? Okay, I got one. Yay. Olivia? Very good. Fa? I think she sits there. Kat, right? Thank you. Let's see here. Millie? Oh, yay. How'd you do? Thank you. And Sierra? Is that right? Okay. Very good. Good job. So do you guys have any questions on what you read? Any questions? No?
I actually have a question.
Okay.
So what's the number that said you have to have, like,
75 hours. Yeah. Yeah. And that's, I was kind of wondering if somebody was going to ask. Okay. So let's talk about that. So in Florida is very unique because we allow challengers in Florida. We're the only state that allows challengers. The only one. Good morning. Oh, we do have somebody joining. Okay. So, oops, that mouse does not work today. Okay. Because we allow challengers in Florida, we don't have an education requirement. So the federal government does, but Florida doesn't. Because Florida is kind of like, we don't really think we're part of the United States, you know. We kind of write our own rules here, if you haven't noticed. Florida, Texas, and California. I don't know why those three, they just are not team players, just not. And we're one of those. So the reason for it, and I kind of have to give you some background, some reasoning behind it. Okay. We all know everybody retires to Florida. I mean, we've seen them all on 19, right? 35 miles an hour. Yeah. Yeah. So Florida is the highest per capita retired demographic. That means a lot of those people are going to need medical care. Now, if we mandate education, right? You all pay $350 a week. And that's because it's a test prep. I don't take you out to do clinicals, and I pretty much volunteer my time, basically. Not a lot of overhead costs other than, you know, what you see here, the room, the insurance, the electricity, that kind of thing. If I made this a 120-hour program, which is what the state requires, right? 120 hours. Good morning, if I converted this into 100, and we did have the 120-hour program for many years, that program is a minimum of $900, minimum, because the overhead costs are much higher. And I have to take you into clinicals. So the time that we're here is much longer. So you guys are getting the same curriculum. The same curriculum I taught the 120-hour program you're getting in here. Exact same instruction. The only difference is I don't take you out for clinicals, right? So if you're getting the same education, do you want to pay $350 for it, or do you want to pay $900? I mean, that's just simple economics, right? Simple economics. How many of you could have afforded to pay the $900 if the $350 was not on the table? So out of a class of 8, I would have 1 show up. That's why Florida allows challengers, because we have such a great need. If we mandate the education at 120 hours, it prices it out of the market for most people. So then we have a need that we can't possibly fill. I mean, we can't fill it now. Right now in Florida, there are 100,000, over 100,000 current CNA openings in Florida, 100,000. Now, I can't possibly teach enough to make up that deficit. All of the schools out there running at peak capacity cannot possibly make enough to combat that shortage. It's just not possible. So we are in a dire situation here. And if we make it even harder for you guys to get certified, we're never going to get out of that shortage, ever. Well, who do you think is the one that suffers if we have this CNA shortage? Who do you think is suffering? Yeah, the patients, sure. Because if we don't have enough staff at Walmart, they just close down a cashier lane and let you do it yourself. Right? Not a big deal. You'll wait in line because it's Walmart. They have done studies showing you'll wait in line. I love this because, you know, federal governments spend money on the stupidest things. They really do. But the federal government actually paid for a study done by a big box store to figure out what the tipping point is for how long you will wait in line. Yep. They actually, they did studies on this. They actually watched when people would leave a line and put stuff back and walk out without anything. And what they came up with, so you guys, you know, all those little surveillance cameras, they're looking at more than just shoplifting. They're actually tracking consumer behavior. Now, Walmart can afford to do that because they get, you know, millions of dollars from the government to do those kinds of studies. But the problem is that they know they can get away with it if they don't have enough staff. You'll go through the self-checkout. You'll wait in line for 22 minutes, by the way. That is the magic number, 22 minutes before you put your stuff down and leave. But healthcare doesn't have that option. If there's not enough staff, we can't tell our patients, well, just go ahead and bathe yourself. If they could, don't you think they would? Trust me, nobody wants you in their private space unless they can't do those things themselves. So nobody's allowing you to do foot care if they can do foot care on their own. So the problem is that we aren't like other industries. CNAs just aren't. So we have to have a strategy that's different from how other industries take care of staff shortages. This is why right now, lots of places are offering hiring bonuses and bigger per hour pay hooks, I call them, right? To get you to come in the door and fill out an app.
You say it's on Indeed,
Yes.
$3,000 bonus, starting at $29 an hour.
Right.
Like, save.
Yeah.
I'll get back to that.
You will be in demand when you're done with this class. I mean, this is one of the few industries that you will always be in demand in healthcare. You can pretty much write your own ticket. You will have multiple job offers. You got to find the place that fits you. It's, you know, when you go to work, you are agreeing to be at another place other than your home for most of your waking hours. You're going to spend more time at work than you are with your family, right? So when most people don't understand this, they go to a job interview hoping they get picked. That is not how this should work. You should be going to a job interview trying to figure out if that's a place that you want to spend your time. You're a commodity. They need you. They need you. And in this job market, that is more true than ever. So when you go for that interview, you should be looking at the place. Is this somewhere that I feel that I can thrive for 8 hours or 12 hours a day? Are the call lights not being answered? Does the place smell funny? How are the staff talking to one another? I listen for that. I listen to that. I will purposefully go to an interview early to sit and listen. How is this place run? Because you coming in there is not going to change anything. So you need to know how it's run, because that's what you're agreeing to. You also need to be really, really careful of really high, too good to be true offers, because if it's too good to be true, yeah, they may pay you $29 an hour, but you have to ask why. Why? They're not doing it out of the kindness of their hearts. Why do they have to offer so much, way more than anybody else in the area, right? Now, if everybody's offered 29, that's okay. But if you got one facility that's offering $29 an hour, you got to wonder why. It's because they've gone through all available staff and the management stinks. And the only way they can get new blood in there is to offer this ridiculously high amount of money, hoping that they'll snag you with the dollar signs. But you still have to work there. And no amount of money is worth your soul. So you have to be careful about those options. Now, I'm not going to say that there aren't good paying options out there. There are, absolutely. And wages are rising for CNAs. And I am really happy to see that. I really am. But just be careful if you're interviewing at a place that's like way outside of what, you know, you've been seeing or is being offered, because that tells you right there that they can't keep staff. You know, so it's something to consider. Now, you may be perfectly happy there. It might be the ideal environment for you. You might be the one person that can kind of change the dynamic, and I've seen that happen. But these are realistic things that you need to look at and think about, but you're going to be in demand. I've got every week, I get 3, 4, 5 employers calling me up and say, are you graduating a class out yet? Because I need them. So far this week, I've heard from Caregiver Services, CSI. I've got some flyers over there for them, I think. I've heard from a small ALF that's looking to hire. I've got her information in the email. I'm going to put it up on the board in a minute. I have heard from a doctor's office that wants you. It's not a bad gig, Monday through Friday. No nights, no weekends, right? And Tender Care, which is a pediatric daycare right down the road behind Finley's Car Wash, they are currently hiring and they want you. So that's just, guys, we're on Wednesday. And that's who I've heard from so far this week. So you're going to be in demand, but we got to learn this and get you certified before we can release you out there to the public, right? For those of you who want to start your job search, and we're going to talk about this in detail on the last, you do realize now I cover everything in detail, right? I leave no stone unturned. So on the last day, I'm going to talk to you about finding a job in healthcare. It's not the same as finding a job in other industries. Okay. We're going to talk about finding a job in healthcare. And on my website, my foryourcna.com website, not the one with the course, but the main website, up at the top, I have different sections. I have training, I have testing, I have after certification, and then there's more. Under after certification, if you click on that one, a menu pops up. The very first one says local employers. That's Hernando County. I have all the hospitals listed, all the nursing homes, all the rehabs, all the ALFs, all the home care agencies. Everybody is listed there under different categories. When you roll over their name, It'll change color. You click on it, it takes you directly to their website with their jobs listing for CNAs. I've done all the work for you. All you gotta do is go to my website, figure out where you want to work, and click on the button, and it'll take you directly to their website. So you don't have to keep typing in and trying to remember who's, you know, what are the nursing homes, or do Google. So I've done it all for you. It took me about a week to build that page. It's a lot of links, but it's really easy to navigate. Okay, so I've done that for you, but we don't really need to worry about that yet, right? We got to learn this first, but I do want you to know that that is there for you if you're looking to start that opportunity. So to recap, the reason that Florida doesn't have that 75-hour minimum is because we have a greater need than we can satisfy if we mandate that education. This does impact you though. So in a lot of cases, if you want to move out of state, now understand that every other state knows that Florida cheats, right? This is an open secret. Everybody knows it. So if you want to move to New York, you can call up New York and you can say, hey, I'm a Florida CNA. I want to be a New York CNA. Is that possible? And they'll say, actually, yes. All you got to do is fill out this form online, send us a couple bucks because nothing in this world is free. And we'll give you a certification in New York that'll allow you to work here. No problem. We like the fact that you've got one in Florida. Good enough for us because it's the same test. You call up Tennessee and say, hey, I'm a CNA. I want to be a CNA in Tennessee. They're going to say, where are you from? Florida? Nope. Nope. If you want to be a Tennessee CNA, you got to go through our training and our testing. We don't accept Florida. Because they know in order to take that test, you did not have to sit in classroom. And this class does not qualify for training because we do not do clinicals. So it doesn't qualify. So this is good in Florida. It's good in about 30 other states. It'll allow you to reciprocate, but not all of them. So if you decide you want to move out of state, you really need to research that before you go. Don't decide on Saturday you're moving on Monday and think you're going to get this accomplished. It takes a little bit longer than that. Okay. Does that make sense? Everybody good with that? Okay, not all states do reciprocity. And it's because of that 75-hour rule. All right, so today we've got a ton of stuff to go over, and I'm going to talk again nonstop for 4 hours. I will. It's amazing I've got that many words. So today we are going to learn range of motion shoulder. We're going to learn dressing a resident with a weak arm. We're going to learn how to take a pulse and mouth care. We're also going to learn all about gloves toward the end of class today. And that takes me a long time to teach you. So a lot of things to cover. One of the questions I get asked a lot is, well, Ms. Patty, why do you teach the test prep and you don't do clinicals anymore? I mean, wouldn't it be beneficial for us to go out and actually practice on real people? And the answer is no. We actually had a much worse pass rate when I did same instruction, same person, same class, same knowledge. But when I let you out in the wild to practice on real people, I have to pair you up with another CNA that works there already. Someone I have no control over. And they teach you all kinds of bad habits before you go to the test. And I end up trying to undo those bad habits before you test. So it makes it way more complicated for me. But I don't know all the things that they taught you. And since every one of you was paired up with a different CNA, oh my gosh, this turned into an absolute nightmare. Because of that, as hard as I try, I've been doing this for 15 years. I got over 3,000 students that have gone through my program, probably closer to 4 now. It's been a while since I've done the math. But that is not all the CNAs that are out there, right? So the chances of you getting paired up with one of my CNAs isn't all that great. So you're probably getting paired up with somebody else that's not teaching you the right things. So yeah, clinicals, not what they're cracked up to be. Yeah, you get some hands-on experience, but you also get corrupted pretty easily because you're still in learning mode. You're still in learning mode. So you're going to take whatever anybody tells you, especially if they're currently working, as gospel. And it's amazing to me how many times I hear this phrase, well, yeah, that's the way you do it in class, or that's the way you do it for the test, but it's not the way it's done here. That is probably the worst statement I've ever heard. And I actually heard an instructor say it recently. And I had to ask the instructor, I get it. I get it. But when that student goes out there after they tested, they get their certification and goes out to work, what foundation did you give them? What do they have to fall back on? Where are they going to go to get those questions answered? Because if you're telling them that what you're teaching them is just for the test, that it has no bearing in real life, you did not prepare them for real life. So what are they going to do when they have a problem? It's very confusing. Yeah, the student automatically goes, well, wait a minute.
What I've been doing all this time.
What? Yeah. And what do I do if I get out there and I don't know what I'm doing? That destroys your confidence. And this is why a lot of CNAs get past the test. They get out into the workforce, and by week 2 or 3, they're gone. They go to work at Kohl's or Steak and Shake or Chili's because, they put all this time and energy and money into a career that they're not prepared to actually do. So remember what I said on Monday, your focus is on the test. My focus is on the day after the test when you have to go to work. That's why, because I've got to make sure that you're prepared for work. It doesn't do you any good to get past the test if you can't actually use it.
It was really, when I worked at the local rehab facility, social services, I saw, because I was there for almost 4 years, so I saw groups of students during their clinicals come in and out, many different instructors. And it was very strange that they would pair them up 2 or 3 students. I don't know if it was a college class or something, probably a college, I would think, because there's large groups. And they put like 3 or 4 with one CNA, and all they did was observe. They had no hands-on experience. They sat there with a notebook, taking notes as they were watching that CNA. They had absolutely no hands-on.
And that's not effective.
I know it's not.
It's really not. No. And you probably noticed a few of them hiding.
Oh yeah, definitely. Sitting there at the very back by the door.
Yeah.
On phones.
Yeah.
Mhm.
Yeah. When we were in nursing school, there was one nursing student that spent all of her time at the nurse's station doing chart review. Every clinic. Did not go in and even look at a patient. Had no practical experience until like a month before graduation, when the instructor said, you need to get checked off on all these skills. You're behind. And she just fell apart. She didn't know what to do. So yeah, it's clinicals are only as good as the instructor, really. They really are, because you guys are all scared. If I took you into a clinical facility right now, you would be scared. You'd be like, I don't know what I'm doing. I don't have the skills yet. I'm just sit here and watch you do it, right? And that's human nature. That's what, that's expected. So instead of just pairing you up with a CNA and say, yeah, go watch this person, go help them out, go see if you can learn something over there. My job is actually to give you very well-defined tasks. You need to find a CNA that's giving a partial bed bath. And then you need to watch it and then do it. That patient's going to get paid twice. You need to find a physical therapist that's helping somebody walk down the hallway. And then I want you to write down 3 things that you notice they're doing wrong. So very focused, well-defined tasks. That's how you conduct clinicals for maximum efficiency. If I just let you loose, you don't know what to focus on. You have no idea. You're the student. You're not supposed to. You're just not supposed to. But I have seen clinicals run very ineffectively. So my job, and this is one of the reasons I keep you here, because I don't trust the people out there to give you the right information. I just don't. So if I keep you in this class, now the only person you're relying on for information is me. I can make sure that I'm giving you what you need to pass the test, which is important to you. But more importantly, I can give you what you need to make sure you're effective on that first day on the job. You're not going to be like, you'll still have some anxiety because, hey, you're a new kid on the block, right? And you're still super slow at bed baths, and that's okay. It's okay. You're new. It's the one time you're allowed to be slow. You're new. But I don't want you to be like, oh my God, I don't even know what to do with the patients. We have a document for that. What's it called? Yeah, the care plan, the chart. Yeah, we have a paper that tells us what to do. Now, you guys, for you, that's normal. That's like ingrained in you because you heard me say the care plan, the whole care plan, and nothing but the care plan about 8 times yesterday, and I just said it again, right? You already know that. To you, it's a no-brainer, right? It's like the foundation of everything. When you go take the test, about half of the people in there will not have a single idea what a care plan is. Not a clue. Not a clue. All they know is there are 21 skills for the test. Here's a list of the skills. I'm going to have to do 3 of them. They don't understand that there are instructions that go with that tell you how to do that skill, and that every patient doesn't get the same partial bed bath. The care plan, every range of motion is not the same. The care plan tells us what to do. Every pulse is not the same. The care plan tells us what to do. They don't know that. So how effective do you think they're going to be the first day on the job? I mean, they really don't know how to be a CNA, do they? They might know how to do foot care, but do they know how to be a CNA? That's the problem. Until about 8 years ago, I was the only person teaching care plan. That's what the test is about. But the instructors, most of them out there, are trying to make you mini nurses. They're trying to get you to think, to reason things out. They want you to put the sugar in the orange juice because they're trying to create many nurses. They don't know the difference. CNAs are not many nurses. You don't think. So that's where I took a national stage about 8 years ago, was to teach instructors how to teach CNAs. Now, a lot of the actual schools are all teaching care plan. They use my system. They use my banners. They use my book. They use my videos. And that's good because we need more of you, right? Well prepared. But there's still a lot of test preps out there that are in somebody's garage that's just saying, these are the 21 skills. This is how you do them. You can go onto YouTube and watch my videos to learn how you can mimic what I do, but you don't really understand what a CNA is, and you fail when you get out there. This is why places have to offer $29 an hour for CNAs, because they can get them in, but they can't function as CNAs once they're there. When I said you guys will be in demand, remember I said the first day, my name opens doors. They know that if you came from this class, you are prepared as a CNA. That's going to help you. It is. You're going to get a certificate from me at the end of the class that will help open some of those doors for you. Okay? But, you know, ill-prepared CNAs have a bigger impact because it's contributing to the shortage. We might have 300,000 CNAs registered in Florida, but not all of them are working as CNAs. They're certified, but they're not actively working because they can't perform. They didn't know what they were getting into. Good. So how do we know what to do with each patient? Care plan. So let's turn to page 53. The care plan is at the very top of the page. You see the little nursey person pointing to the clipboard, says care plan? That is your care plan. So at the top of page 53, we see the title, perform passive range of motion to the shoulder. What body part are we working on? Yeah, the shoulder, right? Can we do the ankle too? No, it's care plan, the whole care plan, and nothing but the care plan. That's right. But I want to bring your attention to something else with this title. It says perform passive range of motion. That's going to be important to us in a minute. I'm going to come back to that in just a second. So remember that term, passive range of motion. But let's read what this care plan is telling us to do. It says provide the following range of motion or ROM exercise to the resident's left shoulder. Flexion, extension, and abduction, adduction. Provide 3 repetitions of each exercise. The resident is not able to help with the exercises. Now, right now, your stomach just clenched. You're like, I don't know what that is. What is flexion, extension? What is abduction, adduction? There's a lot of big words there, and I don't know any of them. I'm going to explain it to you. So look past the big words for a second and understand the intent of this care plan. It is telling us what body part to exercise. It is telling us what exercises to perform, and it's telling us how many of those exercises we need to do. It further goes on to tell us whether the patient can or cannot help us with that. So every range of motion care plan should be very similar to this. Body part, exercises, repetitions, assistance. Okay. So now that you understand the formula that we're going to follow, every other range of motion is going to be exactly the same. If you get range of motion, elbow and wrist, you need to know body part, exercises, repetitions, and assistance, right? If you get range of motion, hip, knee, and ankle, body part, exercises, repetitions, assistance, right? So we're going to learn this range of motion, and we're going to learn 2 more down the road, but they're all the same. They follow the same formula. Okay, good. So go back a page to 51 and let's talk about range of motion. I have to kind of overcome what you think range of motion is because it's not what you think it is. So in healthcare, when you think about exercises, you probably think about things that make people better, right? Because I mean, healthcare, that's our goal, is to make people better. So you probably think to yourself that you're going to go in and do exercises to improve somebody's function. And that cannot be further from the truth. We actually have a whole department that is geared toward exercises that make people better. Anybody know what that department is? Physical therapy. Yeah, all the therapies. Physical, occupational, speech, all the therapies. But let's pick on physical for a second. Anybody know how long a physical therapist has to go to school for?
3 years.
I got 3, 4. I'll give you a hint. It is a doctorate program.
8 years.
10. 8 to 10.
What?
Did
distraction be?
Yeah, 8 to 10 years. Now, physical therapy assistants, right? That is an associate degree program. That is a 2-year program. So physical therapists, 8 to 10 years. Assistants, 2 years. How long are we here?
Oh, no.
4 weeks. Can that be us? No, and that is all they go to school to learn to do is exercise. I mean, that's it. One thing, right? We're learning bed baths and foot care and rolling people over and getting them into. I mean, that is all they are learning in 8 to 10 years, right? We got a whole lot of other stuff to cover. And we're only here 4 weeks. So can that be us? CNAs perform exercises to retain function. Physical therapy performs exercises to regain function. That one letter changes the whole intent. Got it? So all we want to do is keep what's already there working. We're not making anything better. So if you remember on day 1, I told you CNAs do not do pain. We are the only people that don't hurt the patient. That includes this. We're trying to keep what's there, not make it better. So if we get our patient to get their arm to here and they say, ow, do we do ow? Ow is not us. So the next one is going to go below the ow. And then we're going to go find a nurse and say, hey, we got the here, got ow. Figure out why, not my job. Right? We are there to do exercises to keep function that currently exists. So why would we even have to do that? I'm going to tell you a story. Talk about Frank. Frank is an older gentleman in his 70s, recently widowed. His wife passed away not too long ago. And he's very active. He lives alone in his own house. He plays bridge. He plays golf. He does all of his own shopping. He's very, very active. And every Tuesday, he and his brother Ralph go play tennis. And they are highly, have you ever seen brothers? Right? Highly competitive. And on this particular day, Frank hits a volley over to Ralph and he wails on that ball. And when he does, he feels something in his shoulder snap. So off to the ER they go. ER doc says, good news, bad news. The bad news is you tore your rotator cuff, and that's very bad news. You need surgery. And you're probably right-handed, right? He says, yeah. He says, that's really bad news. But the good news is the surgeon has an opening tomorrow and can get you fixed right up. And he says, sign me up. I can't go home like this. My arm doesn't work. So he has surgery. 2 days later, the discharge planner comes in. And she says, you got to go somewhere. We need this bed for other people. You got to be discharged, but you probably are going to need some help at home because you can't like bathe yourself or cook or clean or even tie your own shoes with your arm in a sling. You're also going to need to get to physical therapy and you can't drive for 6 weeks. So you got to have somebody to help you. He says, well, I'm alone. My wife passed away. My brother still works. I'm all alone. She says, what about a rehab? A rehab, there's physical therapy right on site. Just go down the hallway. They can work on that right shoulder, get it right back up and running. And you've got pretty girls to help you with dressing, bathing, grooming, toileting. And he says, sign me up. So here he is in our facility. Now, my job as the nurse is to do a head-to-toe assessment. I'm looking for all real problems and all potential problems. So I'm going to ask you to help him with bathing and dressing. I'm going to ask you to help him with grooming. And I'm going to ask you to help him with eating, cutting his meat, opening his milk, things he can't do right now with one hand. Now, at the end of 6 weeks, we took care of all the stuff that needs to be taken care of. Physical therapy worked on that right shoulder and got it back up to tip-top shape. And we're getting ready to discharge him. But in that 6 weeks, with physical therapy working on the right shoulder and you guys doing everything else for him, how much is that left arm moved? What do you think is going to happen to an arm that doesn't move very much in 6 weeks? Yeah, we actually lose muscle mass. It's called atrophy. And we lose mobility within the joint itself, and it's actually called a frozen joint. So the good news is we fixed his right arm. The bad news is we broke his left. Did we really help him? He's leaving in the same condition he came in it, just reversed. So as a nurse, my job is to do a head-to-toe assessment when he comes in, and I'm looking for all real problems and all potential problems. So I have to know that that is a potential problem. So I've got somebody helping him with bathing and dressing, somebody helping him with grooming, somebody helping him with eating, and you're going to help him with range of motion exercises twice a shift on the left arm to make sure it's moving, that it's getting normal daily movement to keep atrophy from setting in. But we're only going to do what the patient can already do. We're not making it better. We're just trying to keep it from getting worse. So we don't do pain. Make sense? Do you guys have a better understanding of what range of motion is now? More importantly, what it's not? I actually was walking down a hallway once and heard a CNA say, and I'm not kidding, don't be a baby, no pain, no gain. You're never going to get better if you don't do what I tell you to do. I had to go into that room because that is not our role. If you are inflicting pain on a patient, you very well could be producing a new injury because you don't have the skill set for that. Physical therapy can inflict pain because they know how to isolate specific muscle groups and target them. We do not have that ability. Remember, 8 to 10 years, and that's all they learn. They have a wealth of knowledge that we don't possess. Good? Make sense? Okay, so there's 3 basic exercises that CNAs do. There's flexion extension, there's abduction adduction, and there's rotation. So 3 different exercises. I'm going to talk to you about each one in a minute. Don't worry about the big words, okay? But when we're helping somebody with exercises with range of motion, notice we don't call it physical therapy. We call it range of motion. We have a totally different term because it's not physical therapy. But when we're helping somebody with range of motion, we need to find out how much can they do on their own. So if they can do the exercises on their own, then we may just be prompting them, making sure they do it right, giving them critique. And let's face it, making sure they're doing it, because left to our own devices, some of us can get a little lazy and decide, I'll do it later, and later never comes. So a lot of this is cheerleading, okay? So let me explain, let me show you what active range of motion is. Everybody stand up. And now you're going to do calisthenics today, did you? So I want you to take your left arm and extend it above your head like you're asking a question, all the way up. It is straight. Don't let that elbow bend. Reach for the sky as tall as you can. Bring it all the way back down in front of you. Let's do it again. All the way up and all the way back down. One more time. All the way up. Good. All the way back down. That's active range of motion. And that, by the way, is flexion extension. In fact, I used that word. I said, extend your arm above your head, like you're asking a question. Now, I gave you an example that you're familiar with. Asking, everybody knows how to ask a question, right? So giving you an example that you're familiar with took all the fear out of it. You're like, oh, I know how to do that. So let's do a different exercise. Now I want you to bring your arm out to the side like you're making a snow angel. So bring that left arm out to the side, sweeping motion, all the way back down. Let's do that again. All the way up, all the way back down. We always go back to start, right? No half arm, no half arm. All the way up and all the way back down. That's abduction, adduction. Okay, but it's really a side to side motion. Now, rotation's a little bit harder because you're probably thinking about a rotation that's not really a rotation. So rotation of the shoulder is not a pitcher windup. Most people think this is rotation. So try not to hit the wall, but try to do a little pitcher windup. So you might have to stand sideways. Do a pitcher windup. Now feel what that does in your shoulder, right? So think about what muscles that's moving in your shoulder. Now, hold that arm out to the side, palm up. And roll your arm completely over so it's palm up the other way. Now feel what that does in your shoulder. Yeah, totally different group of muscles. This gets deeper. Do you guys feel that? Yeah, if it hurts, you need to do this more. Okay, so this is like your morning calisthenics. They took calisthenics out of school. That calisthenics are very important. So that is rotation. It's not a pitcher windup. It is a rolling motion. Make sense? Okay, different. So go ahead and have a seat. So 3 main exercises that we do: flexion, extension, abduction, adduction, and rotation. How do you know which exercise that patient needs? The care plan, that's right. But those are really big words, aren't they? Flexion, extension, abduction, adduction, rotation, those are just complex words. Let's make it easy. Flexion extension is an up-down motion. And all of this is written on page 52. In my class, you don't have to take notes. I've done it for you. Flexion extension is an up-down motion. When you abduct a child, please don't do that. That's a bad thing, right? But when you abduct a child, you take it away from its family. When you abduct an extremity, you take it away from its family. Adduct brings it back in, adds to. So abduction, adduction go together, the two halves, right? One takes it away, one brings it back. Just like flexion, extension are two halves. One goes up, the other comes down, right? But that is a side to side motion. Abduction, adduction is a side to side motion. Good. Rotation is an around motion. USA. Up, down, side, side, around. That's the easiest way to remember this, USA. Okay. Now, you're not going to do all exercises on all body parts. We have to go by our care plan, but flexion, extension is up, down. Abduction, adduction is side to side. And rotation is around. Okay. Good.
When we're doing those with the patients, and we're explaining it, and say they're not comprehending what we're asking, are we able to demonstrate to them what we're
Oh,
looking
absolutely. Absolutely. Yeah. Patients will fear what they don't understand, especially in medicine. Remember, every person that walks in that room hurts that patient. They expect you to as well. So if you put this in terms the patient understands, you'll get much better cooperation. Because if they don't understand it, they're going to fear it. So yeah, absolutely. I'll demonstrate, but I usually use terms the patient can understand, just like I did with you, right? I'm going to raise your arm above your head like you're asking a question. I'm going to bring your arm out to the side like you're making a snow angel. I'm going to roll your arm up and down. Okay, turning your palm up and down like cookie dough. I'm going to roll cookie dough. When you put it in terms the patient can understand, they tend to fear it less, they resist it less, and you get much better compliance. But if I'm working with somebody that maybe has a language barrier and they don't understand what I'm saying, I have no problem demonstrating it. I'm gonna go up like this and all the way back down. I'll do the work. All you gotta do is relax, but this is what we're doing, up and down. Okay. So what we just did together was active range of motion. I told you what to do. I didn't go around and move all your arms. I told you what to do. I gave you prompts. I made sure you were doing it right. I was your cheerleader, but you did the work. That is active range of motion. So what do you think passive range of motion is? They can't do it for themselves, and we are going to do it. So in this case, I am going to move the part in the direction the care plan tells me to. Okay. Good. Most of the time, if your patient is physically capable of moving their own arm, that we're usually not assigning range of motion to that, because patients just in their everyday activities will move the arm. So generally speaking, we don't do a lot of active range of motion except in an activity room. Now, if anybody goes for an activities assistant or activity director, you're going to be doing a ton of active range of motion by batting a ball back and forth with your patients or clients, by playing balloon baseball, you know, all of those different types of recreational games. Those are all active range of motion, guys. We just make it fun. Passive range of motion is what we tend to do more often. And this is going to be with people that maybe, well, COVID, right? Everybody's aware of COVID, unless you've been under a rock somewhere. There's people in the hospital right now on ventilators with COVID. Do you think they can do their own range of motion? They're sedated on ventilators. But we're hoping that we can heal them enough to get them off of the ventilators. And when we do, we want to make sure that they've still got some muscles to work with. So passive range of motion would be done on those individuals to make sure that we're maintaining that muscle tone while their body is fighting the infection. Or what about patients that have advanced dementia and they're not moving on their own? Well, we don't want them to contract out. Now, contracting is a very normal thing, right? When you don't move your body anymore, all of your tendons shorten. And when your tendons shorten, it bends body parts. And your patient will end up in a fetal position because all of those tendons have shortened and bent all of those body parts up. And you end up contracted. Well, we want to prevent that, right? That does not look comfortable. And your patient will have a lot of long-term consequences from that. So the best thing to do is prevent it. How do we prevent it? Passive range of motion. Keep those tendons active and it keeps them from shortening. Good. Questions? Do you guys have a better understanding of what range of motion is? More importantly, what it's not. Okay. So as a nurse, I've got a lot to think about. I have to think about how, well, the first thing I always think about when I'm doing an assessment is how is this patient going to toilet, right? Everybody has to go. Every single shift at some point. So I got to figure out how are we going to accomplish that. The next thing I got to figure out is how do they eat? Because if stuff goes out, other stuff has to come in to balance it out. So I got to look at their eating. And then I got to look at their mobility. And if I'm noticing that they are not mobile, I've got to address that because that comes with a whole host of potential problems. Things like pneumonia, urinary tract infections, constipation, bed sores, contractures. Yeah, I mean, patients that are immobile, man, they have a whole host of problems that could occur. I got to figure out how to prevent those problems from showing up in the first place. So range of motion is one of the tools that I have in my toolbox. But range of motion is a little bit unique because if I decide that this patient needs range of motion, I have to get a doctor's order for it. It has to go beyond me. I've got to make a recommendation. I think this patient could benefit from range of motion to the shoulder. I'd like to put that on the care plan, and I've got to get a doctor's order for that. I've got to have somebody else with a greater level of education. Remember that doctorate from physical therapy to okay what I want to have done to this patient. Okay. Good. So range of motion requires a doctor's order, but I'm probably going to be the one that comes up with a recommendation through my assessment. So are you noticing that healthcare is done as a team sport? Right? It's not me alone. Alone as a nurse, I can accomplish nothing. Nothing. I may have the knowledge to write a care plan. I may have the skills to do the tasks, but alone, I can accomplish nothing. I have to have collaboration from physical therapy, from the doctors, from the dietitians, from the CNAs, from the social workers. It's an entire team. So if you find yourself in a situation where it's you versus the nurse, there is no team in that. Who's going to suffer? The patient, because it takes a team to make this work. And if you are not playing with the team, or your nurse is not playing with the team, the person that's always going to suffer is the patient. I mean, your life will probably be a living, you know what, but the one that's really going to suffer is the patient, because you can always quit and go find another job. That patient can't quit and find another. Yeah. Okay. So it's always best to try to figure out how to work with your nurses. You're there to assist them. That's what CNA means, right? Sometimes we get kind of focused on the letters. And by the way, I don't like the term CNA. I never have. I don't like that term because CNA is the only industry where you cannot go to school. You can watch some YouTube videos for free, take a test, and get initials behind your name. Think about that. How long did that doctor have to go to school to get his initials or her initials? How long did that nurse have to go to school to get their initials? How long did the social worker, which is a master's degree, have to go to school to get their initials? How long did a dietitian have to go to school to get their initials? And you get them from a gumball machine.
And now they're paying good.
Yeah.
So
But the problem is that your patient does not know where your level of expertise ends. You have initials, therefore you must know what you're talking about. The worst part of it is because you have initials, you think you know what you're talking about because you have initials. And that could be very dangerous. And I'm not the only one that believes this, because a lot of states have gotten rid of that CNA designation, and they now call them state tested nursing assistants. They took that certified out of it because certified means you know something. And that means you're likely to give advice, and you should not do that. So I don't like the term CNA. Helper. You are a helper. You are there to help the nurse. That is what the whole term means. Certified just means you took a test. It shows you know a thing. Nursing, we're not plumbers. Assistant, helper. You are a helper. So, you know, a lot of times online, I see these CNA forums, and, you know, they complain that the nurses aren't respecting them, that, you know, they're, you know, the nurses won't answer the call lights, and those are all valid concerns, but please remember your role in this, right? We are part of a team. As part of a team, we all have an equal opportunity here. but the education and training and knowledge is not. I can't call myself a doctor and start making doctor decisions with an RN education, even though I probably know a thing or two from my experience. It's not my role. If I want to take on that role, I have to go get the education to do so and the credentials. So we have to be really, really careful not to step outside our scope of practice. And that's why we have this banner right here. Okay, this is our scope of practice. We have to be very careful because with initials comes responsibility. But please remember that at the end of the day, you are a helper. It's what you're there to do. Because remember, I've got to assess all these patients. I've got to write up all these care plans. I've got to meet with all these team members. I have got to meet with families. I've got to explain to that diabetic patient why that extra donut is probably not a good idea. I've got a lot of things to do. Now, I also have the ability to put that patient on a bedpan when they ring the call light, or to feed Miss Mary her lunch, or to help Mr. Harvey to the bathroom, or to get a patient out of a bed and into a wheelchair. I have the ability to do all those things, but if I'm doing those things, who's doing my assessments? Who's writing the care plans? Because that takes an RN. So if I'm busy doing all these routine tasks on stable patients, I don't have time to do what I'm there to do. So what I need is somebody that I can point to that can do a routine task on a stable patient to free my time up to do the things that I am trained to do. Does that make sense? So we have to understand our role very clearly here. Good. It doesn't diminish your role. You have a very important role because without you, I can't do me. I know. And I have to be really careful here because I don't want to diminish your role. You are part of a very important part of the team. Very important. But we have to understand that we have to work closely with the nurse and not set ourselves up to be in competition. Because at the end of the day, it's all about the patient. And if we're not focusing on the patient, none of us are doing the right thing. Right? Does that make sense? The reason that I bring that up is you're going to find clicks wherever you go to work. They're everywhere. And if you get involved in a bad click and they sour your opinion, it can create a very hostile work environment. Very hostile. So be careful. Okay? Just remember what you're there for. We all play a part. Good? Make sense? Helper. When we are lifting an extremity to do range of motion, we always want to lift from below with a flat palm. We never like grab from above. We're not the claw machine at Walmart, right? We're not picking up stuffed animals here. If you grab from above, extremities can be heavier than you expect. And when you're grabbing, you've got to put some force into your fingertips to hold on to. Now, you know this if you've ever played the claw machine, right? The whole thing about a claw machine is they have no grip. So if you have no grip, then whatever you're trying to pick up is going to fall. So if you are the claw machine, if you're reaching down trying to pick something up, you've got to have some grip to hold on to it, which means that we can easily bruise the patient. And if we don't grip, the extremity can fall. Neither one of those are good outcomes, are they? So when we lift, we want to do it from below with a flat palm. So we're providing support. Good. Do you remember me talking about the test, how the test is structured on Monday? You guys remember that? Okay. I'm going to tell you a funny story about this. When you get checked in, you need to tell them if you've got any problems that can affect you being a patient for any of these skills. So if you've got athlete's foot, please let them know, right? Because I don't want somebody doing foot care on that foot if you've got a raging case of athlete's foot, right? If you just had dental work, let them go, because I don't want them brushing your teeth and, you know, dislodging something and now you're bleeding and that's going to freak everybody out, right? Well, I had a student, this is probably 10 years ago, who had been in a motorcycle accident and had lost her leg. She had her above the knee amputation. I did not know this because she had had the prosthetic for years and had acclimated to it beautifully. And you could not tell, you know, because she's wearing clothing, scrubs, right? She's not in shorts. I had no idea this woman had a prosthetic until like almost the end of the program. And it did not dawn on me at the time. Real problems, potential problems. Remember that, right? It did not dawn on me at the time to make sure that the evaluator during the test knew she had a prosthetic, because she didn't bring a lot of attention to it. She didn't say, hey guys, fake leg here, right? She didn't talk about it. And I didn't think to mention it. So testing day comes. And the person she's partnered with has range of motion, hip, knee, and ankle. And she's the patient. So she goes and lays down in the bed, doesn't think anything of it, because to her, it's normal. I mean, she'd had this prosthetic forever. Well, when you lift an extremity, you expect a certain amount of weight to it. Prosthetics are very light. So this person testing goes to lift the leg and put some force in it to lift, and the prosthetic comes off. The student that was testing screamed, dropped the leg. My student is laughing hysterically because she thought this was the funniest thing. It's like a cartoon. The evaluator, who had no idea what was happening, is like shocked, doesn't know how to get control back on this situation. The evaluator left the room and came out and was laughing so hard in the hallway, she was crying. So I go up to her, I'm like, because, this was when we were testing center. And I was like, what's going on? She's like, oh my God, someone just pulled off a leg. And I went, oh man, that's my student with a prosthetic. She says, you know about this. Give us a heads up. So if you have a prosthetic limb, please make sure the evaluators know that, because they don't want to pair you up with somebody doing range of motion. The person I feel bad for is the person testing, because how do you overcome that? Right? You are nervous when you're testing. How do you overcome removing a leg? Right? How do you recover from that and go on to finish your test? So I feel really bad for that person. I don't know how they did. But I can just imagine the chaos in that testing room that day. Yeah. So we will learn range of motion, hip, knee, and ankle on next Monday, but let me show you shoulder. So now that we know everything we need to know about range of motion, let's go back and read that care plan one more time, so we truly understand what we're doing here. Now remember, this is passive range of motion. So I'm doing the work. It tells us to perform the exercises to the resident's left shoulder. So we know what body part. It tells us to do flexion extension, which is up, down, and abduction, adduction, which is side to side. And it tells us to do 3 repetitions. Okay. We know that they're not assisting. So we have all the information that we need here to do this skill. But when you're doing this, when the care plan specifies a specific side, make sure that you understand from the patient's point of view. Because if the body in the bed, right? The body in the bed, if I were to lay down, this is my right hand on this side of the bed. So I'm going to put this pin, that's the right side of the patient. But when I approach the bed, this is my right arm, guys. Okay. When I approach the bed, And I think I have to do the right side of the patient, you know, the care plan said to do their right arm. And I'm looking at the patient. Remember, my right is over here, but theirs is over there. So remember, it's not a mirror image. And that can mess you up, because if you do range of motion on the wrong side, it's an automatic fail. Now, why? Why would that be? You just messed up the side. I mean, it's not that big of a deal, is it? What do you guys think? Why?
Because as a senior, you don't know what is wrong with that shoulder that we just done the wrong motion.
Okay, so if the care plan says one side, there's a reason we're not doing it on the other. There's a reason. We don't know what the reason is. We don't know what effect us doing range of motion on that arm have. So during the test, remember that it's always about the patient, never you. So if you're thinking, you know, in your mind, well, I don't know why I failed. All I did was the wrong side. I mean, I did everything else right, just made it about you. You have to think about the potential consequences to the patient. That's what they're grading on. The test has nothing to do with you. Nothing. They're grading that patient. How are you treating that patient? What did you do to that patient? Is that patient uncovered, uncomfortable, injured? Their focus is on that patient, not you. Good? Does that make sense? I need a volunteer, somebody to come over and lay down in the bed for me. Anybody? This is an interactive class.
I wanna lay down because I'm sleepy, so
Oh, I know.
I might be a goner.
And that's a comfy bed too. Now, I'm not going to get into this right now. This is a lecture that I'm going to go over later on in the program, I believe next week. But just for illustration purposes, because I want to draw your attention to it. When I asked her to get into the bed, where did she put herself?
In the middle.
In the middle. She's not staying in this bed. She's only here for a short time. Why did she put herself in the middle? Why didn't she put herself closer to the edge so she could get out? Why did she put herself in the middle? Okay. Were you even aware you did that? No. She did it out of instinct, habit, and it's because it's safer. I didn't tell her to do that, did I? That's going to be important a little later in the program. Tuck that in the back of your mind for later. Okay. So I'm going to do this whole skill from beginning to end. And I am going to do my opening, because every skill starts with an opening. What does every opening start with?
Hi,
A
my name
knock,
is-
right? Yeah, a knock, and then your introduction. Yep. I'm going to close the curtain after I get permission. And remember, for the test, our patients are pleasant and cooperative. So she's going to say yes. She's not going to pretend to have pain. She's not going to do anything crazy. And she's not going to try to win an Academy Award. Okay. So I'm going to close the curtain, and then I'm going to go wash my hands. How long do I have to scrub for? 20 seconds minimum. And what am I going to use to time myself? The clock, not a song, the clock. And then I'm going to do the exercises. And then at the end, I'm going to do my closing. After my closing, I'll go wash my hands again. Now, you're going to watch this from over there. And at the end, when I'm washing my hands, when I'm all done with the skill, before I close it, we are going to review that gray box at the top of the first column. So what's your name again? I'm sorry.
Selenia.
Selenia. Okay, so Selenia, when I'm washing my hands, you are going to read number 1 out loud. And then you're going to read number 2, and then you're going to read number 3, number 4, number 5. So we're gonna go through that gray box together and you're gonna tell me whether I did it or not. Okay? And then if I have to make any corrections at the end, I will. Okay. So here we go. Hi, Ms. Jones. My name is Patty. I'm your CNA today. How are you? Fantastic. I need to do some exercises on your shoulder. Is that okay? Okay. I'm going to close your curtain. Let me go wash my hands real quick and I'll be right back. Now, if I wasn't entirely sure whether I was doing the right arm or the left arm, because I read the care plan, but that was a while ago and I've done a lot of stuff since. If I wasn't entirely sure, I could stop right now and go read my care plan. But I happen to know this is the left shoulder. So I'm going to come over here. I'm going to talk this out for you because you're students. I'm going to turn the water on, wet my hands, get some soap. Remember, you're graded on bubbles, so get lots of soap. And I'm going to start rubbing. I'll look at the clock. I'm going to rub the tops of my wrists, the backs of my hands, and in between my fingers, in between my thumb and index finger, the bottom of my hand by my pinky, and the palm of my hand. All areas, and that is 20 seconds. I'm going to go down each one of my fingernails, between my cuticles. I'm going to circle my nails from the palm of my hand. And then I'm going to rinse. And when I'm rinsing, I don't want to touch the sink or the faucet because my hands are clean, nothing else is. And once I'm done rinsing, I'm going to tap to try to keep the water isolated inside of the sink. I'm going to get some paper towels and I'm going to dry wet clean. Notice I use a lot of repetition in this program. I say the same thing over and over. Yeah, you will hear me in your brain during the test, and that's a good thing for you. It may not seem like it, but it is a good thing. All right, Ms. Jones, I'm back. I'm going to do some exercises. You don't have to do anything at all. I'm going to do all the work, okay? First thing I'm going to do is bring your arm up above your head like you're asking a question, and then back down to the bed. And we're going to do this 3 times. I need you to tell me if there's any pain or discomfort as we do this, okay? All right. So when I lift, I want to support at the elbow and the wrist, right? I'm not just going to grab it like this and do something like this, right? So I'm going to support it at both joints. We're going to go up and all the way back down to start. Feel okay? Up, all the way back down to start. And one more. Go up, all the way back down. Feel okay? Is there any pain or discomfort? Okay, I'm going to bring your arm out to the side and back in like you're making a snow angel, okay? Or in Florida, we'll call it a sand angel. We're going to go up and all the way back down. Feel okay? Up, all the way down. Good. One more. Up, all the way down. All right. Are you comfortable? Would you like any a magazine or anything else before I go? I'm going to open the curtain. Let me get your call light. Remember, the call light needs to be within reach or in the hand. I know this looks suspiciously like a jump rope, but it is a call light. All right, so if you need anything, you just press that blue button. My environment is clean. Okay, remember, comfort, curtain, call light, clean environment. I got all of those done. So I'm going to go clean my hands now. So we don't need anything. Okay. Now the problem is, she's got cooties. And there's cooties all over that place. Cooties. And once I come over here and wash my hands, I'm washing off all of her cooties. So if I forgot to do something, let's say I forgot to give her a call light. Once I wash my hands, if I go over there, what am I going in contact with? More cooties. So once I wash my hands, if I have to return to that patient for any reason, what do I need to do again? Wash my hands again. Got it? Okay, so let's review this together. Selenia, what is step 1?
Opening and washing.
Did I do that? Did I do my opening?
Yeah.
Did I wash my hands? Okay. 2?
Explain all exercises before proceeding.
Did I tell her what I was gonna do, explain it so she could understand? Okay, great.
Collective test and both shoulder.
Did I do that? 4?
Adaptive shoulder, because
Okay, did I do side to side? Snow angel? All right, 5.
each exercise 3 times.
Did I do that? 6?
Monitor for finding things.
Did I do that? Probably a lot, like every exercise. All right, and 7? Did I do my closing?
Not yet.
Okay, well, I did comfort curtain tall light, and I'm cleaning my hands now, but I haven't finished the skill. I haven't completed it. I haven't said my skill is done. Because up until that point, right? So I'm over here at the sink. We just reviewed all this stuff together out loud, but really I would be doing that in my head over here. So if you learn those gray boxes, right, you can over here when you're washing your hands, think about your steps, make sure you got everything you needed to get. And if I needed to make a correction, I could. I could say correction, I would have closed the curtain at the beginning of the skill. Correction, I would have explained the exercises a little bit better. Because, you know, I didn't explain. Correction, I would have done the right side because I was on the wrong side of the bed. Correction, I would have whatever. Once I'm happy with the skill, I can say to the evaluator, I'm done. My task is complete. My skill is finished. Whatever you want to say. Thank you. But you have to end the skill, and they're not going to let you move on until you physically end the skill, because that is you hitting a red buzzer saying, I'm locking this in. If you move on to the next skill and realize you made a mistake, you cannot correct it once you've completed it. Once you've said, my skill is done. You cannot make any corrections after that. So don't be in a rush. Don't get over there to the sink, wash your hands real quick and go, my skill's done. Because you just want to be done with the test. Because you may be able to take a failing grade and switch it to a passing grade by making a correction. So think about it. Make sure that you're happy with your performance before you end the skill, because once you do, that's it, you're done. And remember, once you've washed your hands, if you come back to the patient environment for any reason, anything, you must rewash your hands. Okay, good. Questions? So that is our first skill. Yay! Not too bad, right? Not too bad? Okay, that's good because that's one of the easiest ones. All right. So let's go to page 71. We'll take a break here in a minute.
After the break, I have a letter for
Okay,
I wanted to see together.
that's fine. That's fine. I am recording this. It is on my website. One of the things that I did for you guys after you all got the email, right? One of the things I did last night before, if you go onto my main website, foryourcna.com, I think I'm going to do this for all the classes. I'm not real sure. I'm trying it out with you guys. You're my guinea pigs. But if you go to foryourcna.com under training, the very first link says live class 22AM03. That's your class number, 22AM03. It's on your ID badge, 22AM, 2022 AM class, third one of the year. If you click on that, it will take you to all those links that I sent you. They're now, it'll take you to a page that says class 2, class 3, class 4, class 5, class 6, class. You can just click on it and it'll let you into the live view. But because I'm recording these,
I'm going to try to put them up on there for you. So if you want to review them, you'll be able to. Your own, it's your class that you'll be able to review. Okay. So I'm gonna, like I said, you guys are my guinea pigs here. Okay. You're my guinea pigs. But I'm going to try to render that because it takes a while to render and have it up on that website this afternoon. So you'll be able to watch. Okay, good. All right. So page 71, dress the resident with a weak arm. How do we know what to do with each patient?
Care plan.
Care plan. So anytime we do a skill, the first thing we should ask is, where's care plan? Here it is. This care plan says, dress the resident in a long sleeved button front or snap front shirt, pants, and socks. The resident is lying in bed and has a weak right arm. You might want to underline that. That's going to be important in a minute. The resident is not able to help with dressing. And after dressing, leave the resident in bed. So, couple things. This care plan is like weirdly specific for dressing. I mean, normally it's just like, go get the patient dressed. This is weirdly specific. Now, if you look at the bottom of the page, you'll see that somebody with your level of experience, which is none, should be able to get this done in 14 minutes. Now, I don't know about you, but 14 minutes is a long time to get dressed. I mean, if I'm going out, yeah, it might take me 14 minutes or longer because, I'm trying this on, taking it off, trying that on, taking it. But if I know exactly what I got to put on and I'm just putting on pants, shirt, and socks, man, 14 minutes is a long time to get that accomplished. So you got lots of time here. I also want to point out that it says long sleeve, snap or button front shirt, pants, and socks. Now, if you remember on day one, I said we follow the care plan, the whole care plan, and nothing but that care plan. So this doesn't say anything about undergarments. It doesn't say bra. It doesn't say panties. It doesn't say anything about undergarments. So are we addressing undergarments? No, because we follow the care plan, the whole care plan, and nothing but the care plan. We don't care why there's no undergarments. We don't care. Not our job to care. We're simply going to put pants, socks, shirt on, period. Okay. Now, in a clinical setting, chances are your patient will probably have undergarments. Yeah. But if you look at the bottom of the page in the second area, you'll see this is being done on a mannequin. Mannequins are not easy to move. They're not easy. They're stiff. It's really hard to pull things up and fasten things right. And in fact, the clothing you're going to put on that mannequin is 3 sizes too big on purpose. Because it's hard to dress a plastic Barbie. Yeah. So you need to understand that in a clinical setting, your patient probably will have undergarments that you'll have to help them with. That's okay. That's not really what this skill is about. This skill has everything to do with the whole snap or button front shirt thing. That's what this skill is focusing on. And like I said, it's weirdly specific, right? Snap. I mean, think about what you're wearing. Are you wearing a snap or button front shirt? You're wearing a pullover, right? Something you pulled over your head. Think about your wardrobe. Think about most of the things in your closet. Most of those are probably pullovers. You probably don't have too many things that fasten up the front, do you? But yet this care plan is specifying that we have to have button or snap front. Why? There it is. Yeah. Because when you have limited mobility, a weak arm, it is way easier to dress side to side than it is top to bottom. So when we have a patient that maybe had a stroke and has limited mobility, or Frank from our earlier demonstration, he had shoulder surgery. He had an arm that didn't work very well because it was recovering. So when we have an arm that is what we call affected, we don't use the term bad. Patients can use that. It's their arm. They can call it George if they want to. But we call it affected or weak or impaired. Or you can just use right and left. You don't have to call attention, right? If we have a patient that has a weakness on one side, your care plan will be specific and it will say button or snap front shirt. Now, during the test on the supply shelf, you will have a button or snap front shirt. You will also have a pullover. So what do you think they're grading you on? And that all goes back to following the care plan. Yeah. You're starting to see that the entire test revolves around that care plan. Every part of it. So this also says long sleeve. Guys, the one thing you need to understand is that long sleeves is not always determined by the weather. It can also be determined by the patient's needs. So yeah, we wear long sleeves when it's cold out. I mean, it's cooling down outside. Long sleeves is probably a good idea. But in, you know, the height of summer when it's 102 in the shade, long sleeves may not be your first choice. But if your patient has an autoimmune disorder, that can be affected by sunlight exposure. So if they have lupus, rheumatoid arthritis, psoriasis, Sjögren's, those things can be affected by the ultraviolet radiation from the sun. If they have a weeping rash like shingles, we don't want that skin exposed. We need it covered. If they are on a sulfa medication, which is a popular antibiotic, that can be a very serious side effect, can be triggered by sun exposure. So that actually happened to me when I was 18. I can't take sulfa drugs now. I got an infection, got put on a sulfa antibiotic. And you know the little stickers on the bottle, you know, that says avoid direct sunlight? You know, we don't pay attention to those, especially at 18. Why would I pay attention to that? I'm going to Daytona for the weekend in a bikini, because back then I could, you know. So I'm on my antibiotics for 2 days. I pack up my stuff, go to Daytona, put on my bikini, lay out in the sun for 12 hours, and I turned purple. 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 I had all of my capillaries burst. I had pinprick hemorrhaging all over my body. And it was absolutely horrible, miserable. I could not, it took me weeks for my skin to recover. And it also affected my nerve endings. So when I go into the sun now, my nerve endings will zap me if I get too much sun, like all over my body. It's horrible. So when we have a care plan that says long sleeves, understand that's not always for temperature. Does that make sense? Okay. And most people don't know that. You know, they would think it's 102. I'm not putting long sleeves on this patient. It's not always about temperature. Good. Okay. Are you guys, am I going too fast for anybody? Okay. Are you getting surprised by some things? No? Okay. Yes, no. Okay. All right. So what we're going to do now is go ahead and take our break. And then I'm going to talk when you come back, now that we've introduced this care plan. When you come back, we're going to talk about privacy blankets, which is a whole banner for us. And we're going to talk about the barrier, which is another banner. So we need to learn 2 banners. And then we'll talk about this skill itself, the clothing choice and things like that. And then I'll show you this skill. Okay, so let's go ahead and take your break. Come back at 5:10 on that clock. I'll give you like 2 more minutes. Bye-bye. You too.
So I had to practice. I was late, but I was here. I forgot. I said, what? Oh, I thought we did the stethoscope, and I didn't read the thing. So I had to turn it on. Go on, please get me.
Every time we go in the room, yesterday, I was
Right.
walking on it. And my husband was looking at me like I'm crazy. So I'm like, "You practice." He goes, don't you, that's just common nature to us. I said, no, but I want to make sure that I do this. There's a routine to this.
Sure. I'm good.
We'll start again in just a few minutes. Alright. You want me to turn the air on, or are you guys comfortable? Fine, okay. Yeah, I don't really pay attention to temperature, so if it gets too hot or too cold, somebody can let me know. Just throw something at me and it's my attention. Yeah, hey you. That gets my attention too. All right, so we learned this morning early how to do range of motion, but there were no supplies with range of motion. Right, it's just us and the patient, nothing that we need to gather. This skill, however, we need pants, long sleeve button or snap front shirt, and socks. So we have to gather stuff. So when should we go get supplies? When do you think we should do that? Okay, why? Why?
Because my hands are dirty, my daughter just in dirty.
Very good. All right. So we have our opening, right? Every skill starts with an opening. Every opening starts with a knock, right? So knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here too, whatever. Is that okay? Close curtain, wash hands. Once you have clean hands, then you can go get your supplies. If you go get your supplies before you walk in the room, it kind of takes the patient's ability to refuse away. It's very presumptuous. If I walk in holding all the supplies I need for a bed bath and say, hey, do you want a bed bath? They're less likely to say no because, you know, I'm already there with all the supplies, and it's very presumptuous, and it puts more pressure on the patient. We don't want to do that. We want patients to be partners, not pressured into agreeing. Does that make sense? So we got to wait until we get permission in order to get our supplies. That's how the process goes. But we have to have clean hands to get our supplies because, you know, once you touch that curtain, your hands are dirty. They got all kinds of stuff on them, and you don't want to contaminate your supplies. So the opening goes, knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to whatever. Is that okay? Close curtain, wash hands, get supplies. So getting supplies is always done after hand washing. Good. But now you need a place to put those supplies. And what we're going to use in a clinical setting is an overbed table like this. The problem is that this overbed table is probably not clean. It's held chapstick, cell phones, urinals, lunch trays, crossword puzzle books, used Kleenexes. I mean, this thing is just not clean. So can we put those clean supplies on this table? No, we've got to make a clean service. Now, the test is going to make this easier for you because for the test, your table is empty. You have a blank table to work with for the test. Nothing. It doesn't work like this in a clinical setting. You are not going to have an entire free table to use in a clinical setting. You're going to have to kind of carve out a space around all their stuff, but the test is going to make this easy, plain table, but it's still not considered clean. So we've got to use something to make this surface clean. And that something is called a barrier. So everything that I'm talking about now is on page 64. So again, you don't have to take notes, but we always start with a barrier. So you can use anything as a barrier to separate your clean and dirty areas. I mean, you can use anything. You can use a washcloth, bath towel, paper towel, doesn't matter. Use anything. But for the test, we're going to use something very specific. This is an underpad. More specifically, it's a disposable underpad. Underpads come in two varieties. This is a disposable one, and this is a reusable one, washable. They're both underpads, washable, disposable. So we have to have a way of telling them apart because they're very, very different, right? That's a lot of syllables. Washable underpad, disposable underpad. A lot of syllables. We don't have time for that. This is a bed pad. That's what we call these, the washable ones, bed pads. This is a chucks, because you chuck it. It's the kind of bed pad you chuck when you're done. I know. Don't ask me why they call patient gowns Johnnies. I don't know that. I don't know the story behind that. That's way earlier than me. But patient gowns are also called Johnnies. I don't know why. So this is a disposable underpad, but more commonly we call it a chucks. And it's most of the time you'll see it when you see it written, it's CHUX. Sometimes you'll see it CHUCKS, but most of the time it's CHUX. Okay, chucks. So, everybody with me so far? So I need a clean surface. I'm going to use a barrier. For the test, we're going to use a chucks as our barrier. Now the problem is that I've got to collect other things. I need a pair of pants, I need a shirt, I need socks, and I need a privacy blanket, which we haven't got to yet. I'll get to that in a minute. But that's a lot of supplies. So if I come over here and I get the blanket and I get the socks and I get the pants and shirt, which are currently on my patients, and I've got all of that, and I come over here to the table, I don't have enough hands to spread this chucks out. So what I'm going to end up doing is holding all of this against my uniform in order to open this up and spread it out on the table. The problem with this is that my uniform is not clean. It has brushed up against that curtain. It's leaned up against the bed. It's pressed against the sink. It's kneeled on the floor to do foot care and empty the drainage bag. Things have splashed on it during my shift. This is not clean once I start work. And if I hold these clean supplies against it, I've contaminated them before I've even started. Good. So this order is important. When you do your opening, knock, 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 hi, Ms. Jones, my name is Patty, I'm your CNA, I'm here, whatever, is that okay? Close curtain. Wash hands. And you know you need a barrier, go get it first. Put the barrier on the table. Then go back and get your supplies. Don't try to do it all in one trip, because you're going to end up holding things against your uniform without even realizing it. Good. Questions? So we always start with a barrier. If we need supplies, we need a barrier. It's the first thing we're going to get. And then we'll get our supplies. Good. Remember, you have to have clean supplies or clean hands to touch clean supplies. That might be a written test question. Questions? You just learned a whole other barrier. Yay. Okay, so let's move on now to privacy blanket. This is going to be on page 70. All right, so we're going to use a privacy blanket anytime the patient is uncovered or undressed. That is the biggest rule with privacy blanket. If you are going to be uncovering that patient, they need a privacy blanket. If you're going to be undressing the patient, they need a privacy blanket. If you're going to be exposing the patient at all, they need a privacy blanket. Now, a lot of you are very confused by the curtains. Because when you go in to do a skill, we know we have to close that privacy curtain. And you think in your mind that's privacy. And it is from all the people out there. But that curtain does not protect them from the one stranger that's inside the curtain with them. Who is that? Yeah, you. You are a stranger. And I don't care how many hoo-haws you've seen in your lifetime. They do not want you to see theirs. Right? As healthcare workers, we tend to be jaded. Seen them once, seen them all. Doesn't bother me. I don't care. You know, we tend to kind of pass this off very flippantly. It's not flippant for the patient. I don't care they don't care how many you've seen. It's theirs. And they're not in the habit of flashing it to every talking Dick and Harry around town, right? So we need to understand that we are a stranger, that we are the one invading the privacy here. And that curtain does absolutely nothing to protect them from us. But this is actually a very important concept because healthcare workers have committed some very nasty, horrible crimes against patients. I think we should be talking about that. Right? One of the worst all-time cases was in Citrus County. We had a recovery room nurse that raped over 20 women after surgery while they were still under anesthesia. He was found on top of a 15-year-old when he was discovered. So do you think that patients might have a reason to be concerned over the fact that you are a stranger in their private space and that curtain is blocking everyone else from seeing whatever you're about to do to them? So yeah, the curtain provides privacy, but it also can conceal a crime. Does that make sense? You have to look at privacy curtains a little bit different from the patient's point of view. So making sure the patient is covered anytime they're uncovered or undressed helps provide an extra layer of security for them. Only exposing the area we need to expose at the time we need it exposed goes a long way to garnering trust with patients. Does that make sense? Okay. Privacy blankets are a really big deal. And unfortunately, remember earlier I said that a lot of people say, well, yeah, that's how you do it in school. That's not how we do it in real life. Privacy blankets are probably the worst offender for that. People will learn about it in school and they never, ever, 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 ever practice it. Guys, if I'm the body in the bed, I expect a privacy blanket. And trust me, all of your patients do too. This isn't an arbitrary for the test type of thing. This is real life. How comfortable would you be with a complete stranger stripping you naked in a bed outside of your normal environment with no supporters that could help you? You are vulnerable. How comfortable would you be? I don't care what they say they have to do. You're going to be uncomfortable. Does that make sense? Okay. But there's another reason that privacy blankets are important that nobody ever thinks about. In a healthcare setting, you are fully clothed. You're working. You are dressed. You are in scrubs and they hold in body heat. And you are running around like a chicken with your head cut off. Some of you are probably even cold and wearing a jacket too, right? So you are fully covered and active. What do you think the temperature is going to feel like to you? Yeah, it's going to be on the warmer side. Might even feel hot. Your patient is completely inactive. They are laying in a bed. They are not fully clothed. They are in a paper-thin hospital gown. And they have a sheet over them. What does the temperature feel like to them? Now take that sheet off. Every clinical setting is like -40. It is super cold. When you take that sheet off of the patient, not only do they feel horribly exposed, but they're going to be freezing. It is cold, and we don't think about that because we aren't cold. We're running around, we're active, we're fully clothed. Remember that everything always goes back to the patient. That's the one thing you're going to learn in this class is to quit focusing on you and start focusing on the patient, because that is what matters in this scenario. not just for the test, but in real life, right? But it's hard to make that transition because we live inside our bodies and we're warm. So we don't think about them not being warm. So our privacy blanket is going to be used anytime the patient is uncovered or undressed, period. So if you've got a fully clothed patient that you're doing range of motion on and they're on top of the sheet and fully clothed, do I need a privacy blanket? No. If that patient, if we're doing range of motion shoulder and that patient is in a bed with a gown on, sheet on, and I don't have to move the sheet, do I need a privacy blanket? If we're doing range of motion to the leg and they're in a bed, in a gown, and I have to move the sheet, do I need a privacy blanket? Okay. If I'm going to bathe a patient and I have to undress them to do that, do I need a privacy blanket? If I'm going to do personal care, peri-care, do I need a privacy blanket? Okay, so anytime the patient is uncovered or undressed, you need a privacy blanket. So if you look over and you can see knobby knees, you should not be seeing knobby knees. You need a privacy blanket. Good? Make sense? Got it? Okay, so remember that the privacy blanket covers 2 checkpoints. It's protecting them from you. It's providing privacy, but it's also keeping the patient warm. Remember, there's 2 reasons we use a privacy blanket, not 1. But how you put a privacy blanket on a couch. So if I have a privacy blanket that I'm going to put on the bed, and I get my privacy blanket out, and I've got a patient in the bed, they're covered up with a sheet, I got to put a privacy blanket on. You cannot do what you do at home. Like at home, when I'm making my bed, I'll take the sheet and I'll do something like this to get the sheet to spread out, right? See all those fuzzies that just came up? Those are dead skin cells. Those are yeast particles that this patient shed. That's bacteria. And when I snap this, it brings that right up here, right in level with my nose. So I can breathe all of that in. Now at home, I'm only breathing in my own funk. It's not that big of a deal. I sleep in that bed. It's okay. But in a clinical setting, I don't want to be breathing in somebody else's funk. Do not snap or shake sheets when you put them on the bed. Sheets, blankets, whatever you're putting on the bed. In order to do this properly, when you get your privacy blanket and you bring it to the bedside, remember you don't do this, right? Nothing should touch your uniform. When you bring it to the bed, you want to unfold it and gently spread it out over the sheet. Once you get it over the sheet, then we're going to pull the sheet down underneath. So notice the patient is never uncovered. So we cover them with a blanket and then pull the sheet down underneath to expose the patient so that we can work on the patient. And then I'm only going to move the blanket to expose what I need to expose when I need it. Okay. Now at the end of the skill, when we're all done, we don't want to touch that sheet with gloves on. So if you've got gloves that have touched a whole bunch of things, you don't want to touch this sheet and put whatever funk is on your gloves on the sheet that's going to go right up next to their face, because that's pretty gross. So you want to wait until you've put everything away, removed your gloves, and then you can pull the sheet up. Okay. Remember I told you that if you wash your hands and go back to the patient, what do you have to do again? So you can do that perfectly okay. You can wash your hands and then remove the privacy blanket, pull the sheet up. But don't forget, if you do that, you have to go wash your hands again. I do that when I'm working with chemotherapy patients. I do that when I'm working with HIV patients. Patients that have an immune system problem, I'm going to make sure that I have clean hands when I bring anything up near their face. We're going to talk about that in just a little while, the chain of infection. So kind of keep that in the back of your mind. Okay, face has lots of holes, lots of places for stuff to get in. But at the end of the skill, when I'm ready to take this away, remember I've got an exposed patient under here, right? I don't just want to take this privacy blanket and take it off the bed and leave my patient exposed. It's kind of defeating the whole purpose. So if I've got a patient in bed and I've got the blanket over them, what I'm going to do is, remember I pulled the blanket down under? Now I'm going to put, remember I pulled the sheet down under the blanket? Now I'm going to put the sheet over the blanket and pull it from under. Anything that we remove from the bed, we want to roll up in a ball. You don't want those trailing edges to be able to get everywhere, contaminate stuff. So anything that we remove from the bed, we're going to roll up in a ball so that we have control over it. Good? Questions? I got laundry to do today. All right. Yes.
We were getting our supplies for either changing the bed or getting the oxygen or all of that. In most cases, is there going to be a bag that we would grab as well to put soil balloons in?
Very good question. And I'm actually going to be covering this in detail on class 7. We talked about occupied beds, so I'll cover that in a little bit more detail, but let me give you a short answer. For the test, you will have a laundry basket with the clean supply shelf. Okay, so it'll either be beside the clean supply shelf or on the bottom rack, but you will have a basket for the test in reach. Sometimes they'll pull it out, depending on how big the room is. Sometimes they'll put the basket at the end of the bed to make it accessible, but you'll have a basket available. In a clinical setting, that is not the case. So we're going to talk about that in the last skills day, because I got to get a lot of stuff behind you before a lot of that will make sense to you. But just know for the test right now, that's what you need right now. You will have a basket available. Okay. Good question. Very good. Everybody okay? All right. So because it's been a little while, let's go back and read that care plan one more time. It says, dress the resident in a long sleeve, button front or snap front shirt, pants, and socks. The resident is lying in bed and has a weak right arm. The resident is not able to help with dressing, and after dressing, leave the resident in bed. So remember I said that to underline weak right arm, and I said it would be important later. Well, now is later. When you are dressing somebody that has an impaired mobility on one side, there's a formula that we use. It's called undress strong arm first, USA first. There's that USA again. Undress strong arm first. And then we're going to dress the weak arm first. Now, the reason for this is that if somebody has limited mobility, that means they can't move a whole lot, and movement may hurt. So we want to limit movement as much as possible. Well, if you're undressing the strong arm first, we're making it do all the work. So let's say I have a jacket on, right? And I meant to bring one today and I forgot. But let's pretend I have a jacket on. If I want to, in this arm, it does not move well at all. If I want to remove that jacket, I'm going to pull this arm out of the sleeve. I'm going to make it do all the work. And then the jacket will simply slide right off the other arm. Right? So if you undress the strong arm first, then it makes it do all the work. And whatever you're taking off just slides right off. Well, we're going to do it the opposite way to dress. We're going to slide the new one on without a lot of motion, and then make the stronger arm do all of the moving to get their arm in that sleeve. Okay, so when we have somebody that's going to have shoulder surgery, we actually tell them, hey, go make sure you have shirts that fasten in the front for after surgery. Go get some button-ups. If we have a patient that's had a stroke, we tell the family, hey, button-ups are better, snap fronts. Go find stuff that fastens in the front because they're going to need that. If the patient doesn't have family, we have social workers that can make those arrangements for them. So we have, remember, this is a team sport, right? We don't do this on our own. So we have resources. Now, if you have a patient with a weak arm and you go in to dress them and there are no snap items available, nothing that fastens up the front, who do you think you should tell? The nurse, absolutely. Because remember, it's a team sport. If they don't know there's a problem, they can't solve the problem. And usually it's as simple as picking up the phone and calling a family member and saying, hey, bring us some stuff. We're calling the facility they came from, calling the social worker, we got a problem. And social workers love to solve problems. That is what they go to school to do. I mean, that is, when you take a master's program in social service, that is what you are learning to do, is identify problems and solve them. So they are happy as can be when you give them a problem to solve, because they got skills for that. And unfortunately, we don't utilize social services the way we should. Okay. Questions? One more thing. And I'll show you the skill. One more thing. All right, go back a page to 69, please. Patients have the right to choose their own clothing. So you want to ask during the test, what would you like to wear? The evaluator, one of them is going to describe an outfit that will be on the shelving. They may say, I'd like my blue pants and blue shirt, please. Make sure you're choosing what they describe. If you're at all concerned, you can hold it out to the mannequin and ask, is this what you chose? Even though we're working with a mannequin, the evaluator is going to play the voice of the mannequin. So they're going to answer you. So if they say my blue pants and blue shirt and everything on the shelving unit is blue, you know, you can hold it out and ask, is this the one that you're looking for? But because patients have the right to wear their own clothing. That's actually one of the resident rights that was put in place by federal law. They have the right to choose their own clothing in a residential setting. But sometimes your patients don't always know how to put an outfit together. And you are judged by the way your patient looks. You are. If I walk down a hallway of a nursing home and all the patients are dressed in matching clothing, their hair is neatly combed, they've been freshly shaved, they smell good, I know that the CNAs in that facility are top notch. If I walk down a hallway and the patients are wearing clothes that are mismatched and wrinkled and not buttoned appropriately, you know, it's all cattywampus, and their hair is messy and they look like they haven't been shaved in a week, do I have good CNAs? No, absolutely not. So details count. You are judged on the way your patient looks. That's a simple fact. So if you ask your patient, what do you want to wear today? And they say my pink polka dot shirt and my blue plaid pants. And you're like, oh, no, honey, that does not work. You are allowed, what is that? I don't know what's, you are allowed to, you are supposed to be silent. You are allowed to, I just turned it off. Is it that? No, it's this. Yeah. Oh, okay. All right. It says Selenia has joined my meeting, but I don't see her in here. I keep turning it off, but I'm just gonna turn my phone off. Sorry, guys. There, I'll just turn it off. All right, I don't see her in the room. So because you're judged by the way your patient looks, if they describe an outfit that certainly does not go together, you have the ability to suggest an alternative. Would you like to try your white shirt with those pants? That would look, really nice. Or how about, these pants with that? You can suggest alternatives. If the patient says, no, I want my pink polka dot shirt, my blue plaid pants, you're going to dress them in their pink. But you're going to make sure that even though they don't match, they still look appropriate. They're not rumpled and, they're fastened right. Their details do count. We don't know what the motivation is. The family may be coming today and the son bought the pants and the daughter bought the top. You don't know motivation. And moms will do things like that. Yes, they will absolutely do things like that. So suggest alternatives is okay, but ultimately we're going to honor their wishes. But there's another class of people that just really crack me up. And this is generally older men. Now, sometimes you'll see this with older women too, but it's most commonly older men. When you open up an older man's closet, you'll see khaki pants, 12 pair of them. You'll see the exact same polo in different colors, right? So it doesn't matter what they choose, everything goes together. They can mix and match all day long, but it's all going to be okay. And that's how a lot of people get around this inability to put an outfit together, is they just find one pair of pants they like and they buy 12 pair of them. No thinking involved, right? And that's okay. That's a great coping strategy. Great coping strategy. But sometimes patients that don't have the ability to put an outfit together don't have that coping strategy and they never had to develop it. And this is particularly important in your men that are 90 plus. Everybody's getting older, but 90 plus, because back in the day, have you guys ever been in a really old house, like 100-year-old house, like a really old house? The closets in really old houses were only about this big. And that was for two people, like all of their clothes. Now, that doesn't work for us. I mean, we have to have entire rooms now devoted to clothing. We call them walk-in closets or rooms. I saw a house on Realtor the other day that had a 2-story closet. Oh yeah, I was all over that. I mean, the house is like 5.6 million. I can't afford it, but I was all over that closet. Seriously. But we, in our experience, we don't understand that. We don't think about, we don't know it, because back then Walmart was not in every town. I mean, Walmart didn't come around until the 80s. So when you've got clothing that must be handmade, or even department store clothing that was horrifically expensive, a lot of these people grew up with 3 outfits. That was it. That was all you had. You had what you wore yesterday that's being washed, what you're physically wearing today, and then you've got one set of Sunday best that you use for church, weddings, funerals. And once it gets a little worn and ratty, then it moves to your daily wear and you get a new Sunday best outfit, which was only every 5 or 6 years. So clothing back then was not what it was today. This guy, when he got up in the morning, didn't have to think about what he was going to put on. He didn't have any choices. That was it. That's all he had. Well, that man probably joined the military. That's what you did back then. Join the military, Uncle Sam makes you a man, and they give you 3 sets of clothes. One you wore yesterday, one you're wearing today, and your dress, blues, whites, greens, whatever your branch is. After the military, within 6 months, he got married, because that's what you did back then. You found yourself a wife. She stayed home, cooked, cleaned, and laid out your clothes for the next day. So even though he's working in corporate America, he's got clothes in his closet now. He has never had to pick out an outfit. Wife did that for him. She laid out his clothes on the chair for the next day. So he gets up. Does he have to think about what to wear? Nope, it's already done for him. Now, fast forward, he's 96 years old in your facility, and you walk in to say, hey, what do you want to wear? I don't know. I've never done that before. This is not a stupid man. Do not treat him like he's stupid because he lacks this one skill. Help the man out. Help him out. If he says, I don't know, suggest an option. Or sometimes what they do is they'll just say that shirt, those pants. And if they don't go together, let him know. Hey, these pants would go better with that top. And he'll probably say, yeah, that's what I meant.
Or why you asking?
Yeah. Or why did you ask me in the first place? Yep. Yeah. We ask because it's polite. But I'll tell you that when I'm working with somebody for a long period of time and we get to know each other, you learn what's expected of you from that client. Okay. But as far as the test goes, right, we ask every day, every patient, they have the right to choose. Does that make sense? Understand that is a legally protected resident right. Just like the right to refuse. Patients have the right to refuse. And another one that will really surprise you, patients have the right to freely communicate with others. Now, the fact that this is a federally protected resident right tells you that it wasn't always that way. Think about that for a second. Can you imagine being in a nursing home and being told you cannot communicate with your family? Talk about frightening. And yet that's the way it was before 1996. 1996. That's when resident rights were finally adopted at the federal level. Crazy, right? So we have to be very careful to protect these rights and to understand just how important they are. To you, it probably doesn't make much sense, but to somebody who's been in healthcare long enough to remember when this was not a right, we have to do everything we can to protect it, to make sure it doesn't go away. Because one day we will be the patients, right? And this is why when COVID hit and all of these places shut down and wouldn't let visitors in, that was a direct contradiction of the federal right that patients have. So that's why it was such a big deal legally. So don't think that it can't happen again, because it just did. It just did. And it doesn't take much to hop from, oh, pandemic, we're going to put this into place, to, we're just going to get rid of those resident rights. They don't really matter anyway. So our job is to really make sure that we're protecting that by asking, what do you want to learn? Good? Yeah.
The care plan, like a button shirt. What if the resident said, I don't like that? I like
The pullovers.
pullover. Who follow the care plan? Or
Yeah, and that's a really, really tough situation. But I'm here to remind you that healthcare is a team sport. So you really do need to talk to the nurse about that, or whoever's coordinating the patient's care. So this is where it gets tricky, right? We talked a little bit on the first day about people working privately. Okay. So if it's just you on care.com and you're contracting direct with a patient that you're going to come into their house and take care of them, that's your team. Your patient is your team. There is no care plan for you to follow. There's no nurse involved. That's your team. So you'll take your direction from them. If the family hired you, that's your team. You'll take direction from them with input from the patient where possible. If you're working for a facility or an agency, that's your team. So it may be a nurse, it may just be a supervisor, but that's your team. You need to talk to the team. And that's the one thing I've got to get, you know, and I know I pound this into you a lot, but healthcare is a team sport. There's always a team. It may just be you and the patient, but it's a team. It's still a team. Could be you and the family. It's still a team. You're not there alone. Okay, good. All right. So undress strong arm first, stress weak arm first. Questions? Okay, I'm going to show you the video for this one just because it has good close-ups. And there's a lot of detail work with this skill. So I want to show you the video for this. And I'd be happy to help you live. You know, when you're practicing this, I'll help you with it. But let me show you the video because it does have really good instruction. But when you're watching this video, I want you to pay attention to what I say to the patient. Now, I know it's a mannequin. You know it's a mannequin. But listen to what I say. I explain every step I'm taking. Now, part of that is because it's a teaching video. I'm teaching you guys what to do through this video. But even if you didn't exist, even if this was me and the patient, I would say the exact same things. Because nobody wants to be touched and their body parts moved without you knowing exactly why and what's happening. Right? Remember, this is a complete stranger touching your body and undressing you. You probably have a right to know why and what's going on and what's coming next. So one of the questions I get asked a lot by students is, do I have to say everything you say in the videos? And the answer is, yeah, you should. You really should. You should. And there's a couple reasons. Number one, it helps the patient. Number two, it helps you remember your steps. But remember those evaluators that are grading you? They got that checklist in front of them, which means that they have to check things off of the checklist. So where are they looking? They're looking here. If you're doing something over there and they aren't looking up to see it, if they don't happen to see it, but you're saying the step out loud, you get the check mark. So remember, their focus is split between you doing the skill and the checklist that they're checking off. So talking out loud for the test can actually improve your score. Got it? Okay, those of you that are, I'm going to try to do the replay. I don't know how it's going to work. But if this does replay and I can get this loaded up on the website, the video that you're watching here will be hard to see because it's on a screen. It looks small. Go watch the video under skills videos on my main website, foryourcna.com, training, skills videos, dressing a resident with a weak arm. Thank you. I told you guys I talked nonstop before. And I don't like to talk. I got so much to tell you. Okay, so in the bottom of your page, it tells you how long somebody with your level of experience should be able to complete this skill in. And I believe this one is 14 minutes, right? Okay, so when I hit this play button, I'm gonna look at the bottom and I'm gonna tell you how long this video is. And I guarantee you it's nowhere near 14 minutes. And remember that this has a whole beginning sequence and a whole credit sequence that's going to be built into that time. So what I need you to understand is the time that they allot for you to do these skills is way more than you actually need to do the skills. So don't feel like you're under pressure to rush. You're not. There's way more time than you actually need. So this is 7 minutes and 5 seconds. And remember, you've got 14. And that includes all of this. That should look familiar to you. That's the care plan we just read.
Hello, Mrs. Jones. My name is Patty. I'm your CNA today. How are you? Good. I'm going to help you get dressed. Is that okay? Okay, I'm going to close your curtain. Let me go wash my hands, get my supplies, and I'll be right back. The first thing that I'll get is a barrier to put on my table to make sure that my supplies remain clean. Mrs. Jones, what would you like to wear today? Your light pink pants and dark pink shirt? Okay. Is this the outfit that you described? Wonderful. I'll get a privacy blanket as well. Okay, Mrs. Jones, I'm going to spread this privacy blanket out over you. This will keep you warm and help protect your privacy as we do this still. I'm going to carefully unfold the blanket. Be careful not to snap or shake it as I lay it out over you. Once the blanket's in place, I'll pull your sheet down to the end of the bed. Okay, Mrs. Jones, I'm going to place your socks on now. We'll take one of the socks, stretch it all the way up to the toe seam, put it over the foot, making sure the toe seam is lined up, lift from below and support at the ankle, and smooth the sock over the heel. Now we'll go to the other side. We'll stretch this sock up, put it over the foot, making sure the toe seam is lined up, lift from below and support at the ankle, and smooth the sock over the heel, minimizing wrinkles. Now I'll help you put your pants on. We're going to make sure the tag is in the back. I'm going to insert one of my arms into the legs of the pants and stretch it up so I have control over all the material. We'll then place it over your foot, lift from below, and smooth it over your heel. We're going to repeat on this side. I'm going to put my hand inside to stretch up the leg of the pants. And then place it over your foot. Lifting from below and supporting at the heel while we finish putting on your pants. Okay, Mrs. Jones. Now I'm going to lift your pants up over your hips. If I can have you raise up your hips as high as you can. On the count of 3. 1, 2, 3. I'll make sure that your pants are over your hips. And then cover you back up. Okay, Mrs. Jones, I'm going to elevate the head of the bed now. Please tell me when you're comfortable. And if I can assist you to lean forward, I'll untie your gown. Thank you. I'm going to tuck a corner of the blanket behind your back as you sit down. And now I'll remove the gown from this side. We're going to undress the strong arm first. Since our care plan indicated your right arm is weak, we'll undress your left arm first. I'm going to the other side of the bed now. Okay, Mrs. Jones, I'm going to undress this arm. Being careful to minimize the movement and support the arm at the elbow as I lift it off the bed. We'll remove the soiled gown. We'll go ahead and rest your arm back on the bed. Okay, now I'm going to assist you with your shirt. I'm going to scrunch up the arm of the sleeve and put my hand through backwards, keeping your arm supported on the bed. I'm going to lift your hand and hold it as if we're shaking hands. This will keep all your fingers together as we place the sleeve over my hand and then over yours. Once we have the sleeve in place on your arm, we'll extend your arm out while support at the elbow as I bring the sleeve the rest of the way along your arm. If I can have you sit forward, Miss Jones, let me assist you. Thank you. Make sure that you remain covered and smooth the shirt along your back. Come on back, Mrs. Jones. Thank you. Okay, Mrs. Jones, I'm going to assist you to put in your other arm and your sleeve. So I'll stretch it up. Put my hand in through backwards. And Miss Jones, if I can help you reach your arm up and back for me. I'll assist you to put your arm in the sleeve. Okay, Miss Jones, we'll rest your arm back on the bed now. We'll straighten your shirt and make sure that it is snapped appropriately. Okay, let me just adjust your clothing to make sure it's neat. Can I have you lean forward for me, please? Thank you. I'll make sure that this blanket can be removed. Okay, Miss Jones, I'm just going to gather up your privacy blanket and place it in soiled linen along with your gown. I'll be right back. Okay, Mrs. Jones, I just want to adjust your clothing for neatness of appearance and make sure that it's fastened appropriately and that you look good. Very nice. Okay, you have your ball line here. You should need anything. Can I get a magazine for you? Okay, I'm just going to throw your barrier away. And open your privacy curtain. Now we'll go wash my hands. After washing my hands, I'll think about the steps of my skill, make any corrections, and then tell the evaluator if my skill is done.
Thank you. Any questions? Questions? No? No? Okay. All right. So on page 71, at the bottom of the step-by-steps is a little gray box. It says, check your knowledge, answer the questions below. I want you to answer those 5 questions quickly over the next couple of minutes. This is on page 71 at the bottom of the first column. All right, so let's go through this. When a patient has a weak arm or limited mobility, you will, what do we do the strong arm first? Undress strong arm first. Very good. This care plan requires that this patient wear long sleeve button or snap front shirts. Yes. Are undergarments required for this patient? Will other patients require undergarments? Sure. Every patient's different. Every care plan's different. Consult the care plan. Yeah, it's an easy answer, right? We eat, breathe, and sleep the care plan. And at the end of the skill, make sure the resident is dressed appropriately or neatly, however you want to put it is fine. But take a minute to look at them. Sometimes we get so caught up in the steps that we forget to look at the patient. Look at the patient. Make sure they look good. Details count. All right. Questions? No?
Yeah.
Okay.
I didn't notice it. It could be because of my vision as well in the video. When we're doing anything with skin contact, even just putting a shirt on, do we wear gloves?
We are going to get to that in about 20 minutes.
Sorry.
No, you're fine. But I'm actually going to point that out. That the skills that we've done so far, we haven't worn gloves, and I haven't even talked about gloves. So where does that come into play, right? So that means that we have a little bit of learning to do about gloves, and I'm going to go over that in just a few minutes once we get past pulse. So let's segue into pulse. Let's go to page 35, please. And I guarantee you, I am going to surprise you with what I have to tell you about gloves in a few minutes.
It's like a COVID, everything is mask gloves. When you even see people walking through Walmart with mask gloves, shields. Like
Remember that when we get into the conversation we're about to have. But let's get through this first. I know, and you are not alone. By the time I get to this point in day 2, everybody's like, well, gloves, what's going on? And I'm not talking about gloves, and you're like, what's going on? Why, what did I miss? But I put mouth care purposefully at the end because I want to build up your questions about gloves, because I'm about to blow them all out of water. So let's do pulse first. So how do we know what to do with each patient? Yeah, you guys should be singing along with that one. Care plan, care plan, care plan, care plan. Your eyes should immediately go to the top of the page and be reading the care plan before I even start talking about the skill. You should know this care plan before I show you the skill. So this skill says patient will be lying in bed for the skill. Take the patient's radial pulse measured at the wrist for 1 full minute and record your reading. So not only do they tell you what pulse they want you to take, they even tell you where it's at. They don't expect you to know where the radial pulse is. They tell you it's the wrist. But there are lots of pulse points on the human body. You've got the radial pulse at the wrist. There's also another pulse at the wrist at the bottom called the ulnar. We're not using that one. What does our care plan say? Radial. So keep that in mind. But we also have brachial, which we'll get into on Monday when we learn blood pressure. We have axillary, which is under the arm. We use that in kids. We have apical, where we listen to the heartbeat. We have femoral. Please don't use that on the general public. They don't understand why your hand is in their groin. You also have popliteal, which is in the back of the knee. You have dorsal pedalis at the top of the foot. And you have carotid, which we use when we think our patients are dead. Only when we think our patients are dead. Because patients will get anxious if you put your hand around their neck. Right? Great way to initiate a pulse if patients have one. So carotid is only used when we think our patient is dead. So CPR, because it's the biggest pulse point in the body. But this care plan is very specific. It says radial measured at the wrist. So let me show you where your radial pulse is. So to take a pulse, we do not use our thumb. Your thumb has an artery in it. And if you compress the artery, you'll actually feel your own pulse through your thumb, which isn't going to help you a bit if you're trying to measure somebody else's, right? So don't use your thumb. 2 fingers, not just one, 2. And when you're taking a pulse, you need to be using the top of your fingers, the tips of the fingers. You have way more nerve endings at the top than you do the flat surface. Okay. And that's because we have finger dexterity, right? We do things with our hands, and we generally tend to focus on fingertips. So that's why it has more nerve endings. So if you just lay your fingers like this, you're probably not going to feel the pulse. You want your fingers to be bent, so you're using the fingertips. Okay. So everybody got that so far? Now, let me show you where your pulse is. So if you hold your hand out like you're going to shake somebody's hand with your thumb pointing up, you have a bone that runs right along the top of your wrist. Find your bone. And you want to be at the bendy part of the wrist, not way down here. You want to be really, really close to where the thumb starts, way up at the top. Now, if you put your 2 fingers at the top of that bone, just like stand up like you're going to go cliff diving, right? So you stand up on your bone, and then you roll forward and put your thumb on the back. Okay, so stand up on the bone, kind of roll it forward, fall down, and then put your thumb on the back. You should feel some thumps underneath your fingers. Should feel some thumps. Yours is up a little bit high. So when you stand on the bone, oh, you should be close to, do you feel it? We want to be way up here, a little bit closer. Okay. Right there. Relax your wrist. Relax. Put your thumb on the back side. Make sure you put your thumb on the back side. Do you find it? Find it? Did you find it? Good. You good? Okay. The reason your thumb needs to be on the back, like you can put your fingers there and find it. It might show up. But how long does this care plan say we have to count for? 1 full minute. You guys know how long a minute is? Oh my gosh, it's like forever. Your fingers will relax if it doesn't have anything to hold opposing pressure. So if you just set your fingers there, you might find the pulse, but over that minute, your fingers are going to relax. You're going to lose it. You will lose it. So when you find the pulse and put your thumb on the back of the wrist, that holds your finger in a C shape like this, and it will hold consistent pressure so you don't lose it. Good. Okay, so find another pulse. So you find each other's pulse. Don't count, just find the pulse. Find the pulse. In fact, you'll need to stick here for a little bit. Sorry.
Like doing each other's.
Yeah, just
Okay.
find it. I just want you to find a pulse on somebody else. Got it? Okay. Maybe up toward the ceiling a little bit more. Yeah, somewhere in there. Got it? Okay, so you guys all know where a pulse is now. Normal pulse rates are between 60 and 100. That's normal. Okay, normal pulse rate is between 60 and 100. What would you do if you were counting somebody's pulse and got 52?
Report it to the nurse.
Report it to the nurse. Easy answer, right? Report it to the nurse. What would you do if you got a pulse rate of 116? Report it to the nurse. Do we have to solve that problem? No, we're just finding a problem to report. That's it. If it's between 60 and 100, write it down, document it. So anything outside of values gets reported, anything inside of values gets documented. But when you're documenting, pay attention, because that's a wide range, right? 60 to 100. That's like a really big range. So if you've got a patient, you take their pulse and you get 62, normal. 60 to 100 is normal. You get 62, that's normal. And you go to document that in the patient's chart. And all the other pulses that you see are 98, 96, 94, 96, 102, 94, and you have 62. What do you think you should do with that information? Right, because it's not normal for the patient. Even though it's normal, according to our range, it's not what the patient normally runs. So that could indicate a problem, couldn't it? Does that make sense? Good. So when we're doing vital signs or any sort of measuring anything, we have to know our normal values, but we also want to pay attention when we're documenting what's normal for that patient. And if you notice a discrepancy, report it, because this patient might actually have a 3rd-degree heart block that just showed up. And if I don't know that, it's not going to get treated. And now we may have long-term kidney damage because the kidneys aren't getting blood the way they're supposed to. And that could have been prevented if you had just told me that the pulse is running low for the patient. Good. Okay. So what we're going to do is our opening, knock, knock, knock. Hi, Ms. Jones. My name is Patty. I'm your CNA today. I need to get your vital signs. Is that okay? I'm going to close your curtain, wash my hands, and then I'm going to take the pulse. Now, when you're doing this for the test, and I'm just going to show you on my mannequin. Remember, this is a live person because mannequins don't have pulses. This is a live person. I'm just going to show you on her real quick. But if I do my opening, wash my hands, and I come over here to take the patient's pulse, and it's a live person, right? I'm over here, I've got the pulse. The evaluators have to be able to judge whether I'm accurate, which means they're on the other side taking the pulse too. And I'll explain to you why that would be accurate in just a second. I'll explain what a pulse is in a second. But do you think this position is comfortable for me? For a full minute. Now I could raise the bed up to comfortable working heights because hospital beds are adjustable, right? We don't have this feature at home, but a hospital bed, the whole thing raises up to a comfortable working height. I can make this thing go whatever level I want it to so that I don't have to bend. This is really nice for making beds, turning patients, transferring, and all that. And when I say it goes high, I mean it goes high, like really high, right? So you can do this for the test. There's no problem with this. But if you don't return that bed down to its original height, it's an automatic fail. Automatic fail. And that's because you guys don't have one of these at home. How long have you been sleeping in a bed? Since you're probably about 2, right? So in all of that time, from 2 until now, when you climbed into bed, you put your little toesies in the bed and you lay down, and you sawed some logs, and you woke up really groggy the next morning, and you swung your little toesies out, that floor was always right where you left it. Never moved a day in its life. Predictable. And you're groggy, which is a good thing, because when you put your feet out, you expect the floor to be there. It's always been there. If we move this bed up to a comfortable working height, is that floor going to be where the patient expects it? And they're not expecting that. So they will stand up as if the floor is there, and if it's not, what happens? They fall. Has nothing to do with the fact that the bed is high. It has everything to do with the fact that you moved the floor. If you don't return that bed to the low position, it's an automatic fail because your patient has never had that floor moved, ever.
So you can raise the bed up to a comfortable working height. But for this skill, there's actually something you can do that's even easier than raising the whole bed up and then having to remember to put the whole bed down. Just raise their forearm. Okay, keep the elbow on the bed, raise the forearm, and I've got adequate, access to their wrist. This doesn't hurt me, it doesn't hurt them, and it saved me a ton of time. Make sense? This is not appropriate though. Why wouldn't this be appropriate? Yeah. Oops. So you don't raise the whole arm up because it puts a lot of pressure along those muscles, or you're having to grip tight because extremities are heavy. You want to leave the elbow on the bed and just elevate the forearm so it's always supported. Good? Questions? Okay, so remember I said I'm on one side, evaluators on the other side, they're gonna count when I count. How many evaluators are there? Uh-oh. Patient's only got 2 arms. I've got 1. Evaluator's got 1. That's a problem because they have to be able to grade you independently. So this is the only skill that you have to do twice. Once with each evaluator. So if you get pulse as a skill, you're going to do your opening. You're going to count with evaluator number 1. They're going to let you write that down so you don't have to remember it. And then you'll count with evaluator number 2, do your closing and write that. Okay. They'll tell you that if you get the skill, they'll tell you how to count with each one. Good. Okay. So let's talk about what a pulse is. So you have a heart on the left side of your chest. That heart squeezes. When that heart squeezes, it pushes out a wave of blood. That wave pushes the one in front of it. That one pushes the one in front of it. And that one pushes the one in front of it. This is how waves of blood move through your circulatory system. Heart squeezes, a wave goes out, pushes the ones in front of it, like waves of an ocean. If I were to cut a hole right here and let you see into my artery, you would see a wave and then a valley. It would just like trickle. And then a wave would come through it and then it would trickle. And then a wave would come through it and it would trickle. When we are taking the pulse, what we're doing is holding that artery down a little bit so we can feel those waves as they go through. That's all we're trying to do is feel the waves. So if we count the waves, then by extension, we know how much the heart beat during that minute. That's why a pulse will tell you the heart rate. Good. It's indirect. I mean, we're not like watching the heart. We're feeling the waves, but those waves tell us that the heart was beating and how fast. Good. Make sense? That's going to be important again on Monday when we talk about blood pressure. So what we're going to do now is take each other's pulse. So I'm going to ask you two to stand up. And I'm going to ask you to come sit here. I'm going to have you come sit here. Okay, so you guys are going to put both of your arms out on the table. Just you two. Both your arms out on the table. You're going to find the pulse in that hand. You're going to find the pulse in this hand. Now, when you're taking a pulse, there's a couple different holds that you can use. I can come from above this way. I can come from below this way. So you've got a couple of different holds that you can use, depending on which side of the patient that you're on, what's going to be comfortable for you. Now, for the test, remember your patient's laying in bed. Right? You get to pick which side of bed you want. So you probably want to pay attention when you're practicing to which hold is more comfortable for you, so you know which side of the patient to be on. Okay, so go ahead and find the pulses. Don't count, just find the pulses. When you have the pulse, say yes. Yes. Just a little bit.
So I'm gonna say start. You're gonna count the thumps you feel under your finger until I say stop. And then when I say stop, I'm gonna ask you what you got. We're gonna see how close you guys are. We're gonna see how close you guys are. Okay, ready, set, start. Stop. Sierra, right? Okay, what'd you get?
Yeah, 75.
Right?
Yeah.
Okay.
I have 91.
Okay. Okay, very good. So you guys are very close, right? You guys were right on. Now for the test, you can be off by 4 beats in either direction of the evaluator's reading. It's a big margin. So now you are going to be patient with both your arms out. You're going to be patient with both your arms out. Okay. So you're going to put both of your arms. So you're going to find the pulse in one arm, you're going to find the pulse in this arm. And when you find the pulse, are you right-handed?
Yes.
Okay, so take the right hand. And when you have the pulse, say yes. Still don't have it. So I want you to tell me whether I'm pressing harder or softer. Okay, that's what I was thinking. Hers is buried a little bit deeper, so you gotta put a little more pressure. Are you right-handed? Okay, so I'm just gonna bring one over here. Okay, that may be a better. I feel. Okay. You're welcome. Okay, ready? Everybody good? Ready? Set. Start. Stop. Get. What'd you get?
I felt like 60.
Okay, that's okay.
72.
Okay, very good. How long is that minute? A long time, isn't it? Yeah. Okay, so you guys are now the patient, with both of your arms out. Your pulse. Go ahead and find the pulse. So when you find the pulse, say yes. Got it? Got it? Good. Okay, ready? Set. Okay, what'd you get? Anybody?
My
What'd you get?
76.
Okay, that's okay.
Yeah, it's
That's okay. What'd you guys get?
59. 50.
Okay, very good. Okay, so you guys can return to your seats. So, what's normal? Between 60 and 100. So most of you are within normal range, close to it, right? Some you were a little bit low, right? Okay, let me explain why and why I'm not concerned. So as a CNA, your job is to take the pulse and report anything abnormal to the nurse. It's the nurse's job to interpret that and to figure out whether it's cause for concern or not. So he is relatively physically fit, and I would venture to say he probably does some sort of cardio. Do you run? Do you play tennis? Okay. So that is something that I would assess during my initial assessment. Remember, real potential problems. So I'm looking at things like, what do you do for work? What do you do for hobbies? What do you do for exercise? What kind of habits do you have? So I'm gathering information because the heart is a muscle, just like every other muscle in your body. If I spent all day in the gym doing curls, I'd have biceps. Clearly I don't, okay? But I would have biceps to kill for, right? Because I'm exercising those muscles all the time. Now, people that are cardio athletes, people that do a lot of cardio, running, cycling, swimming, tennis, that type of thing, the muscle they're working on is their heart. So each one of those compressions, each one of those squeezes the heart makes pushes out way more blood than my heart does. My heart goes something like, because I don't do cardio. Kind of half-hearted, push out a little blood, keep you alive, you know. His heart, because he does a little more cardio, is stronger than mine. So when his heart squeezes, it does it with some gusto. Whoosh, whoosh. So his heart doesn't have to beat as often to push around the same amount of blood as my little wimpy, right? So cardio athletes tend to have a lower resting heart rate. In fact, Lance Armstrong, the cycle guy, right? His resting heart rate is about 38. And he's perfectly healthy, right? I'm not concerned about his heart rate because his heart is so strong. I mean, this guy takes cardio to an extreme. I mean, that's his job, right? Where I spend, 8-10 hours here selling scrubs, teaching classes. He spends 8 to 10 hours a day on a cycle. And then after that, for fun, he goes on a bike ride, So he is constantly working that muscle, making it stronger, 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 stronger. So I would expect his heart to push out a ton of blood with each compression. Good. Now, on the other hand, if we had a bodybuilder, somebody who spends all of their time in the gym, doing the biceps curls, the tricep curls, the lats, right? Our gym rats. They're big, bulky built. Man, they got all kinds of muscles bulging everywhere, right? But you know what muscle they're not working on? The heart, because cardio leans you out. And if you're a bodybuilder, you don't want to do a lot of cardio because that's not bulking, that's leaning. So we've got all of this body to feed, right? Lots of blood, because every cell needs blood. So it's got all of this muscle mass to feed, and we didn't make our heart any stronger. So what do you think a heart rate of a bodybuilder might be? High, that's right. Isn't that cool? So anybody know what this is? These became very popular during COVID. They're now being sold everywhere. This is a pulse ox. This will tell you how much oxygen you have in your bloodstream. We'll see how good I am right now. But at the bottom of the screen, it also shows my pulse rate. So this doesn't need a full minute. We had to count for a full minute, right? So this is not counting for a full minute. So my resting heart rate, but it measures it and it displays it over a minute because all pulses are reported over a minute. Now, sometimes we can take a shortcut in a clinical setting. We can count for 15 seconds and multiply that by 4 to get our full minute, right? As long as a patient is stable and the heart rate is regular and all the boxes are checked and everything is normal, that's perfectly okay. But if we got a problem with the patient, or maybe they have AFib, their pulse rate is irregular, or maybe they just had a medication that we want to evaluate, in that case, a full minute is a much better gauge. Does that make sense? So how do we know which one we have to use? Care plan. So if you look at this, you'll see my oxygen level is at 98 and my pulse rate is somewhere around 71-ish, 68. It's bouncing between 68 and 72, right? So that's my pulse. This is a whole lot easier than counting, isn't it? This is being used in most clinical settings now. Very rarely will you actually take a physical pulse, but you still need to know how, because machines can fail, batteries can die. These things can get dropped and knocked out of calibration, especially because they're portable. If I drop this thing, it's no longer accurate. So you have to know how to take a manual pulse, but in most settings, you'll be using one of these instead. Okay, good. And that concludes pulse. Ready to move on? Let's talk about gloves. All right, so go to page 26 for me. Everything I'm going to be talking to you about will be on page 26. I do have a video for this. So if you're interested, you can go to my main website under training, animated videos. You see that little video clapboard there? That tells you that I have a video on my website. These are always under animated videos. All right, so let me explain this. Gloves are not what you think they are, and they're actually not used correctly in most places. And I'm going to give you a demonstration that's going to show you very clearly why thinking about gloves the wrong way can put everybody in danger. And it has nothing to do with healthcare. How many of you guys have ever gone to a sandwich shop where they make a sandwich in front of you? We won't say the names of the chains or grocery stores that we go to, but we all know that there are places you can go and they make sandwiches in front of you. You probably don't want those people touching your food with their hands, so they wear gloves, right? So we're going to build a sandwich together. And I'm going to take your instruction and I'm going to build the sandwich. So what kind of bread do you want?
White bread.
White bread. So I'm going to put my food service gloves on because I know you don't want me touching your food. So I'm going to put my food service gloves on and I'm going to go to the oven, the bread warmer. I'm going to open the door, pick out a loaf of bread and close that door. We're going to put it on the counter. I'm going to pick up the knife that's on the counter and cut that bread in half and lay it open. Would you like any condiments, mayonnaise, mustard, honey mustard? Okay, so I'm going to reach into the mayonnaise container that's like a little knife spreader that's sticking out of it. And I'm going to pick it up and I'm going to spread it on the bread. No mustard? Okay, we'll put the mayonnaise knife back in the container. What kind of meat would you like? Okay, so I'm going to open up the little fridge thing that's underneath the counter and look in. Oh, we're out of turkey. Hold on a minute. I'm going to go to the back cooler, open up the cooler, walk in, get the container that has all the cut meat, open the lid, reach in and get the turkey out, close the lid, come back out, close the door, put the turkey I'm going to use on the counter and put the rest of it in the refrigerator. So I'll open up the fridge, put the turkey in and close the fridge. And now I'm going to spread that turkey on the bread. Would you like some cheese on this? Okay, so I'm going to open that fridge, get what, oh, do you want provolone or cheddar? Or, okay, so I'm going to reach in and get that out, close the fridge and put that, oh wait, I got to cut it though, right? So I'm going to pick up that knife again and I'm going to cut it in those little triangles and I'm going to put that on the bread. Would you like this toasted? Okay, so I'm going to put it on the paddle, open the toaster, put the whole, paddle thing in there, close the toaster, turn the little dial to set it, and we're gonna wait, and then it dings. So I get the paddle and pull the thing out, close the toaster and put it back on my table. Would you like some lettuce? So I'm gonna reach into that lettuce bin with my hands and get the lettuce, shake some out and put it on the sandwich. Tomato? I don't want normal sandwiches. Okay, so we're gonna get some tomato, maybe some pickles. Should I get some olives? Okay, so I'll squeeze those out and put those on too. Do you want oil and vinegar on here? Okay, so I'm gonna get the oil and spread it on, and the vinegar and spread it on, salt and pepper. Okay, there's a shaker there that has both in it, so I'll pick that up and shake that on there liberally. And now I'm going to wrap the half a sandwich up in the wrapper, and then I'll wrap the other half a sandwich up, and then I'm going to get the bag and put it in the bag, and then you're going to go down. Oh, she's on break. Okay, I'll ring you out, no problem. So I'll take one glove off to touch the cash register, and I'm going to hand you a cup because you got the combo clearly. And did you want chips or a cookie with that? Cookie? Okay, chips you get yourself. Cookie, we're going to open the cookie container, get a cookie out, put it in the bag, close the cookie container, and here's your receipt. And then I'm going to go back over here and build another sandwich. I'll put a new glove on this hand, and I'll build another sandwich. But they wore gloves. So what you're telling me is that gloves do not keep things as clean as you would like. Now, before this conversation, did you ever pay attention to anything they touched?
I always like the part where you said, like, when it's time for you to pay,
Mhm.
I would always be like, you just gonna take my card or
Mhm.
my money and you still have a glove on.
Yeah.
So,
Well, in this case, they actually took one off, which was, nice. But yeah, a lot of times they won't even take the glove off. Now, guys, your sandwiches are perfectly okay. You have functioning immune systems. We need a certain exposure to keep our immune systems active, just like every other body part. If you don't use it, you lose it, right? So a little bit of exposure is okay to keep your immune system active. So there's nothing wrong with the sandwiches. Go have one for lunch. It's okay. But this demonstration is designed to show you that we touch things with gloves all the time without even being aware of it because it's part of our routine. But everything that we touch is going to contaminate those gloves. Now, in a sandwich shop, it's not as critical as it is in a clinical environment when you're working with C. diff patients. And the problem with this is, if you remember on day one, I told you the people at risk are the ones in the bed because they already have an immune system that's actively fighting something. And if we contaminate their environment by touching a bunch of stuff and then touching them with those gloves, then they may not be able to fight that off. Does that make sense? So wearing gloves for everything is dangerous because, just like the food example I just gave you, when you wear gloves routinely, you stop paying attention to what you're touching with those gloves. That sandwich builder did not realize all of the things that they touched because they're focused on the task. The rule is you wear gloves when you make a sandwich. They wore gloves when they made a sandwich. What's the big deal, right? Well, in healthcare, the rule is you wear gloves when you see patients. So if I'm wearing gloves when I'm seeing patients, I'm not paying attention to everything I'm touching in the environment. And what's the big deal? Is it a big deal? So we got to be smarter about glove use. And there's a lot of people out there that will tell you that you put gloves on when you walk in the room and you take them off when you walk out of the room because you don't want to be exposed to anything that patient has. And I get it. I don't want to be exposed to anything the patient has, but if I'm doing this correctly, and I'm washing my hands at the beginning of every skill, and I'm washing my hands at the end of every skill, and I'm wearing gloves when it's appropriate, and I'm paying attention to everything I'm touching with those gloves, I am not at risk. We need a higher level of awareness, not a higher level of fear. Does that make sense? So wearing gloves routinely does not get you where you need to go. So that's the first thing I need you to get rid of. Okay. So having gloves on for range of motion when your patient is fully clothed and isn't leaking anything, it's not necessary. You washed your hands before, so you got clean hands to touch the patient with. You're washing your hands after, so any cooties you came in contact with are gone. What do those gloves do for you? Now, this changes though if your patient has shingles. Yeah, weepy rash, right? That changes things, right? So we have to have some rules to work with here. We need rules. We have to know, when do we wear gloves? When do we not wear gloves? There's got to be some rules here. So we do. We have 3 rules. They're very easy. You need to ask yourself 3 questions when you're going to do a skill on a patient. The number 1 rule, number 1 question is, during the skill, is there a chance I could come into contact with anything ooey gooey that's not mine? If it's wet and sticky and came from somebody else, I don't want to touch it without gloves. I need an extra barrier. So if I could potentially come into contact with anything ooey gooey that's not mine, I probably need some gloves on. So if I'm doing range of motion, my patient's fully clothed and not leaking a thing, don't need gloves. If they got shingles, I need gloves. Ooey gooey. Got it? Now, if the answer is no to ooey gooey, if I think, is there anything ooey gooey there that I might come into contact with? No. Looks good. I'm going to go to the second question. The second question is, am I going to touch any skin normally covered by a bathing suit? Personal skin. So this is the breast area on females, the genital area on both sexes. I'm not going in anyone's personal skin without another layer. And that's emotional comfort for them, right? They don't want my bare hands around their little dangly bits, right? So I need gloves to touch personal skin. Plus, there may be some ooey gooey residual that I don't want to come into contact with. So if I'm going to be near personal skin, I need to have some gloves. So ooey gooey, personal skin. Now, if the answer to both of those is no, if I'm doing range of motion to the shoulder, they're fully dressed, holding on to all of their own body fluids like a champ, right? I don't need no ooey gooey there. No personal skin contact there. So let's go to the third. Am I going to get into contact with any non-intact skin? This would be body openings like eyes, nose, mouth, genitals, rectal area, wounds, sores, rashes, incisions. Any area of the skin that is not intact. Because non-intact areas let stuff out of the patient. They also let stuff in. Remember that every hole in your body is a 2-way door. Let stuff out, let stuff in. So if I'm going to touch anywhere on the body that is not intact skin, I need some gloves. So when I'm going to do a skill, I always look at the patient and I go through a checklist. Ooey gooey, no. Personal skin, no. Intact skin, it's all intact. I don't need gloves for this patient. If the answer to any of that was, well, maybe, I need gloves. If the answer is, I don't know, I need gloves. If the answer is, yeah, I'm going to be all up in their business, I need gloves. But the answer is no to all of those, I don't need gloves. Now, why can't I just wear them even if I don't need them? There's 2 reasons. Aside from you start touching stuff and not paying attention. which we just learned. There's two other reasons. Number one, those gloves do not do what you think they're doing. They do not cover you. They are not a magical suit of armor. Stuff gets through gloves routinely, all the time, under the best of circumstances. And I'll prove it to you. Have you ever seen a birthday balloon? One of those latex balloons, it's blown up by helium, bops up against the ceiling for a couple days. What happens to that balloon after a couple days? Yeah, it shrinks, it deflates. That's because latex, same stuff your gloves are made out of, guys, same stuff. Latex is a man-made material. Every man-made material has holes in it. They're microscopic, they're super small, and it takes a while for this to happen. That's why the balloon stays inflated for a while. But as you inflate that balloon, the material of the latex stretches. Well, what does that do to the holes? Makes it bigger. And over 24, 36 hours, the helium molecules inside the balloon are able to get out through the holes. And then the balloon shrinks down. So the first thing you need to understand is your gloves have holes. And if helium can get through, you really think viruses are going to have a problem? Viruses are 1,000,000 times smaller than helium. That glove is not a magic suit of armor. It does not keep everything out. In fact, they've done many, many studies on this. They have cultured the hands of people, healthcare workers, after they've washed their hands. They've had them put gloves on, go do a task, and then take the gloves off and culture their hands. And every time, let me say that, every time the second culture grew. Under the best of circumstances, your gloves are still letting things in. So when you take your gloves off, what do you think you should be doing? Washing your hands. And yet that's the part of gloves that's so dangerous. And we saw that in the example I just gave you, right? They took one glove off, they gave you your cup, they got your cookie, they took your money, and then they put another glove on without washing their hands. Do you guys remember, we talked about this on Monday. I told you that pathogens need 3 things to thrive in an environment: warm, dark, moist, right? Anybody ever wear gloves? What does it make your hands do? Sweat. It's warm, it traps body heat, it blocks out light, and the sweat is moist. So under that glove is the ideal breeding environment for every pathogen known to me. Now we know pathogens got through, and we just gave them a soupy mess to frolic in. If you aren't washing your hands after you take those gloves off, you are just allowing that to proliferate. And everything you touch is spreading those germs all over the environment. And the problem is that psychologically, just like the sandwich thing, right? We had this false sense of security. We were happy in our ignorance. As long as they're wearing gloves, making our sandwich, we're good, we're happy. We didn't realize all the danger there. Well, when we are working in healthcare and we take off those gloves, we think in our minds, oh, I was protected, I wore gloves, I don't need to wash my hands. And we take that contamination over to the next patient. Washing your hands is way more important after you've removed gloves than anything else you do, because it breeds a false sense of security, and you will end up culturing a ton of horrible things on your hands that you're spreading throughout your patient environment. You're spreading them to your cell phone, you're spreading them to the nurse's station, you're spreading them to the elevator. When you go down to lunch, you're spreading them everywhere. And this is why we can't get control of the pathogens in a clinical setting. It's because of us. Good. Did you learn something? But there's another reason that you don't want to wear gloves routinely. I am not an environmentalist. I don't know if you know this. I drive a sports car and I like to go fast. That thing eats gas like there's no tomorrow. I don't recycle. I should, but I don't. I am not an environmentalist. I live on 10 acres. I'm not a tree hugger though, okay? But this, what I'm about to tell you, understand I'm not an environmentalist, but this impacted me. Those gloves that you put on are not biodegradable. That means that every pair of gloves that you put on is going to be on this planet 100 million years from now. Think about that. We tend to put gloves on, throw them away, and we don't think about them again. They're gone. Now, back in the 80s, we took care of this by burning all of our medical waste. My first job in a hospital was right next to my office, right next to the incinerator, which was awesome because I was always warm. It was great. And we burned everything. Every patient use item went into that incinerator, burned it all, and everybody else did too. And that was great. Got rid of all of our medical waste, except it caused this little ozone problem. Like we created a hole in our ozone layer from burning all these plastics. So they told us, don't do that again. Quit that. So they did. Now there's no more incinerators in hospitals. They're gone. So we piled up all that medical waste, just piled it up. Now, when I say pile up, understand the scope of the problem here. We in medicine, I'm not talking about healthcare, manufacturing, dental, housekeeping. I'm not talking about that. I'm just talking medical. We in medical produce enough used gloves to fill a football stadium 35 feet deep every day. Every day. And guys, that's just America. That is just America. These things aren't biodegradable. They aren't going anywhere. So we just like put them in landfills, special landfills, put them in landfills, put them in there. We'll figure something out. Well, somewhere along the line, somebody says, you know, that's not sustainable. We can't do that anymore. Let's find a place to put them. So in their infinite wisdom in the 90s, they put them in big metal containers. I mean, huge metal containers, poked a whole bunch of holes in the top, took them out to the Pacific Ocean because nobody's using them, and threw them in, and they sunk to the bottom, and they created these artificial reefs. And that's what they called them, artificial reefs in the bottom of the Pacific. And we just kind of out of sight, out of mind, throw all of our medical waste in there. Nobody knows. It's fine. It's fine. It's fine, right? Except now the fish we're pulling out of the Northern Pacific, we can't eat because they have high levels of latex. Guys, we poisoned our own food supply. That's not sustainable. So someone said, let's not do that anymore. So now we can't burn it because of the ozone thing. We can't drown it because of the fish thing. So now we're back to landfills. Now, this is not going to be my problem. I'm out of here in like 30 years, right? I don't have that much longer ahead. Not my problem. This is going to be my granddaughter's problem. 35 feet deep every day. This is going to be my granddaughter's problem. So, does it make sense to keep using gloves when we don't need them? Especially when we have to wash our hands before we put them on and wash our hands when we take them off. And we were going to do that anyway. Does it really help? If you're touching ooey gooey, personal skin or non-intact skin, wear an extra layer. Don't forget to wash before. Don't forget to wash after. After is super important. Please don't skip that one. But if we don't need it, if we're washing our hands before and after and everything is intact and we're not touching anything ooey gooey, do we really need to contribute to this problem? Something to think about. Now, when you're out there working, I can't control what you do. If you want to wear gloves at every patient encounter, wear them. But understand that every decision you make has consequences. And please, above all, if you're going to wear gloves routinely, wash your hands and make sure you know what you're touching with those gloves. Just like the sandwich bag. Make sense? Did you learn something? Yeah, I know that lecture really challenges people. They're like, wait a minute. Wait. We wear them at Walmart. Yes, people wear gloves at Walmart. And they push the cart and they touch the ketchup. And then they get into their car with those gloves on. Yes. Yes. So I think we need a little bit better knowledge and understanding than just routine. And that's why I go, guys, it would be so much easier on me. You have no idea. If I could just tell you, yeah, wear gloves for everything. Just put them on, take them out, just wear them for everything. It's fine. Man, that lecture is quick. It's easy, it's simple, but it doesn't get us where we need to go. This takes time to explain and to drag you there. Because I know some of you are resistant, right? I got to drag you there piece by piece, little by little. This takes time. And nobody's going to persecute you if you're wearing gloves all the time. But I want you to understand that there is a consequence to that. Okay. In the meantime, I'm driving my little race car and I'm having fun.
So how come, for the, this is kind of along the hand washing kind of thing. How come now with they still are focusing with the hand washing, which has been around forever, hot water, soap, clean hands, versus hand sanitizer?
Okay, so hand sanitizers are appropriate for medical use. Perfectly okay. And they can take the place of hand washing as long as your hands are not visibly soiled. And in some cases, hand sanitizers have actually been shown to be more effective than hand washing. So because the hand sanitizer actually breaks down the envelope. So every pathogen has kind of like a bubble that they live in. It's a protective envelope, right? So the sanitizer breaks down that envelope. Now we used to add this stuff to soap called triclosan, which broke down that envelope, but it caused a lot of problems, particularly bacteria or resistant bacteria, resistant strains of bacteria. So they took that out. They don't let the general public really, get into soaps, because if you don't kill all, quickly, because I'm way out of time. But no, this is so important. Yeah, this is so important. You need to understand this, okay? You know how you have an immune system? When your immune system sees a pathogen, so a pathogen invades, your immune system notices, hey, you don't belong. Your immune system has to figure out how to kill whatever's invading. That's how it works. So it tries spitballs, and then it tries dropping an anvil on its head, and then it tries shooting bows and arrows, and then it tries stabbing. Eventually, your immune system figures out how to kill them there, right? And when it does, it spreads the word. Hey guys, I figured it out. This is what works. And there's a little secretary that takes a note and puts it in a filing cabinet, so that when that invader invades again 5, 10, 20 years from now, the secretary goes in the filing cabinet, says, oh yeah, I remember, this is how we kill it, and gives the word out. And that's why you don't get infected the second time. Everybody got it? Way oversimplified, but that's the basics. Pathogens have that same system. Exact same system. They're like, okay, they try to kill me with a spitball. This is how you evade that. Spread the word. They try to kill me with an anvil. This is how you evade that. Spread the word. They try to kill me with. So if we aren't successful at killing that invader with whatever we're throwing at it, it spreads the word on how to evade it. So you put this stuff in the soap, you give it out to the public, and they don't use it right. Well, that's really one of our biggest weapons. So that would be like, you know, these ballistic missiles, sending them over to Russia and say, yeah, take notes. This is how we build them. This is what they do. Go ahead, take some notes, right? And then expect it to be effective. It's not going to be effective. They know all about it, right? So that's the problem, is that people don't use these things. How many of you guys have ever taken an antibiotic? How many of you finished every single pill in that bottle? Every time.
No.
Guys, you just showed them, you showed the bacteria our secret arsenal. You showed it to them. And because you didn't take every pill, you didn't kill every one of them. So what do you think they did with that information? Yeah, absolutely. They spread it on. And that's why we have drug resistant, right? So that's why hand sanitizers are often preferred in medical settings, because it actually like kills the envelope that holds the pathogen, breaks it down. So it's effective in 99.9% of applications, so it's okay. But again, we're not using it right. We don't use hand sanitizer right. So you guys have all used hand sanitizer, right? This is my little germ guy. Hand sanitizer. So when you get a hand sanitizer, you probably get about that much. When you use hand sanitizer, right? That was 4 seconds. My hand should have been wet enough for 20 seconds of exposure. What else is 20 seconds? So if your hands are gonna be wet for 20 seconds, you know, we don't use enough hand sanitizer, and we don't get all of the areas. So you got little secret agents hiding out in all those little nooks and crannies that now have access to your secret weapons. Now, the other problem with hand sanitizer, so I just use that, right? So what happened to all those pathogens that are on my hands?
They stay on there.
Yeah, they don't pop into the atmosphere. Even if I managed to kill them, right? Even if I used enough and managed to kill them, they didn't disappear. Now I'm walking around with dead E. coli on my hands, which isn't much more appetizing than live E. coli, especially if I'm going to go eat a tuna fish sandwich. Right? So if you're going to go eat, should you be using hand sanitizer or washing your hands? Yeah, because when you wash them, the E. coli goes down the sink, not on your sandwich. Yeah, have you ever seen those little old ladies at Walmart that cashiers, you know, they wear gloves when they're checking you out, right? So they wear them for a 4-hour shift before they go on break. And their hands in those gloves have sweat. And remember, stuff has gotten through. So they've got this big, wet, soupy mess on their hands, right? From sweat and bacteria and stuff. And then they take the gloves off and they go eat, and they think to themselves, my hands are clean because I've been wearing gloves. And they don't realize that all the stuff that's on their hands when they're eating their sandwich is just mind-boggling. But here, you know, this is another example how a little bit of information in the wrong context can be way more dangerous than keeping to the basics. Just wash your hands. Just wash your hands. I don't know why people have so many problems with go wash your hands. Just, it's not that hard. Yeah. Now I use, I do use hand sanitizer. I've got them on my purse. If I'm going through a drive-through at McDonald's, it's better than nothing. But every time I use that hand sanitizer and I bring a fry to my mouth, I know that I'm bringing E. coli along for the ride. You know, so after you realize that for a while, you do tend to make at least the stop before you go into the drive-through and wash your hands. But we live, like I said, your immune system needs a little bit of a workout. So a little exposure is not bad. It's not bad. Your immune system needs to be kept up to date. But, you know, within reason. Okay, good. Questions on gloves? Okay, so I know we're out of time. I'll get you mouth care on the, I can play with the schedule. We got plenty of time, so I can play with the schedule a little bit. But we'll cover that on Wednesday. But what I want you to truly understand is that you must wash your hands at the beginning and end of every skill, regardless of whether you wear gloves or not. That's non-negotiable. Non-negotiable. And you also need to understand that things may have gotten through those gloves. So be careful with, you know, what you're cross-contaminating. Okay. So the skills that we learned today, range of motion, shoulder. That patient was fully clothed, laying in the bed, holding onto all of their own body fluids. Did I need gloves? We also learned dressing a resident with a weak arm. Now we're assuming they already have undergarments on. We're not putting them on. We're assuming they're already there, right? So no ooey gooey, no private areas, no non-intact skin. Did I need gloves? No. What if the patient had shingles? Yes. Okay. We also learned pulse. So no ooey gooey, no personal skin, no non-intact skin. Did I need gloves? What if the patient had an incision on that arm? Okay, starting to get it? Questions? So guys, we've learned, remember, we already know skill rules. We follow the care plan, the whole care plan, and nothing but the care plan. If we can't do that, we notify the nurse. We know the opening. We've heard it a million times now. Knock. Hi, Ms. Jones. My name is Patty. I'm your CNA. I'm here to whatever. Is that okay? Close curtain, wash hands, get supplies. But we also today learned the barrier. That's the first thing we get is the barrier, and then we go get our supplies. We don't hold supplies against our uniform, and we need a clean place to put our clean supplies. We learned how to evaluate whether we need gloves or not today. That's a principle. We learned privacy blanket. Anytime the patient is uncovered or undressed, we need to use a privacy blanket. That protects them from us, but it also keeps them warm. We're going to put it on over the sheet, pull the sheet down underneath so we're not exposing that patient. We have learned the closing. Every skill ends the same way with the closing. So right now, we have half of those banners done. And it's only class 2. I know it's time to go, but you have 2 chapters of homework tonight, chapters 2 and 3. It will take you a little bit longer. Budget your time accordingly. You all have access to the online program now. That's available to you. How many of you guys activated that? Okay. All right. So that's available to you. You can certainly go in and do the lessons that we covered in here today. I'll just bring mouth care down to Monday's class, but please on Monday, I need you to bring your blood pressure cuffs and stethoscopes. And I'd like you to bring a can if possible. I think I probably have enough, but we wrap the blood pressure cuff around and we practice inflating and deflating. That way it saves your neighbor's arm.
A can?
Yeah, like a Lysol can, you know, even that, is that rigid? Okay,
This one, no.
no, the water bottle, yeah, is that rigid? Yeah, even that might work, but it's the size of a human arm. Okay, Lysol cans work great. I mean, that's kind of the best thing, or scrubbing bubbles can, or big hairspray cans, not the little skinny ones, bigger ones. But I think I have 8 in there. There's only 8 of you. Bring your blood pressure cuffs and your stethoscopes for sure. Okay, did I get too fast? Is anybody unhappy with the class in any way? If you're concerned, if you are unhappy, if you don't feel like you're learning appropriately, please stay after and let me know. This is your class. I'm just here to help you through it. Okay, I want to make sure that you're comfortable with where we're going. Other than that, try to do something fun this weekend, right? It is a weekend after all.
My daughter's birthday.
Ooh, that's fun.
Went to go on Disney walk Sunday.
Oh, wow.
She's 18.
Oh, I went to Disney World for my 18th birthday too. You know, just a couple of years ago.
But now we're going inside. Too expensive.
Oh, yeah, it is expensive for sure.
She said she just wanna eat there and
Oh, you're gonna go to downtown Disney? Yeah, that's fun. Yeah, I can't wait. In 3 weeks, we have Sun and Fun over in Lakeland, which is a big air show. I go to that every year. That's the only family thing we do. We've been doing it since my kids were little. And yeah, it's just a ton of fun. I can't wait for that. Couple weeks. I'll be sunburned. Go have a great weekend.
You have a good one.
Hey guys.
Have a good one.
You too.
I'm going to put some of my